Good evening, everyone. Thank you for joining in today for the Lung Cancer Conclave. On behalf of myself, Dr. Sushant Mittal and Dr. Samit Purohit, we would like to invite our chairpersons and panelists and attendees and hope that this Lung Cancer Conclave will be an academically fruitful discussion for all of us, for professors, for consultants, and for the PG residents as well. So with this kind introduction, I would like to invite Dr. HP Singh. He has recently retired from RNR Hospital. He's a medical oncologist. And Dr. Doval sir, who needs no introduction. He is the director of RGCI. So we'll hand over the mic to both the chairpersons. So welcome and good evening.
Good evening. Shall I start, Dr. HP Singh?
Yes, sir. Dr. Doval sir, we may start.
Okay. So the first talk is by Dr. Devvrat Arya, who will be talking about on immunotherapy in locally advanced and early lung cancer. Dr. Devvrat is with Max Group of Hospitals, and I think without wasting any much time, I would invite him for his talk. Dr. Devvrat, please.
Yeah, thank you very much, sir. Good evening to all. I hope I am audible and the slides are visible now.
Yes, you are audible and the slides are visible.
Yeah. So good evening, Dr. Doval. Good evening, Dr. Singh. Good evening, Sushant, and good evening to everyone who's attending this meeting. And the topic that I'm going to talk about is the role of immunotherapy in early lung cancer. And we all know that like all other cancers, lung cancer has been divided into stage 1 and 2, which are considered early, in most cases treated with surgery. Stage 3, which is a locally advanced, 3A can still be treated with surgery, but 3B onwards, it's mostly combination of chemotherapy and radiation therapy, as they are considered unresectable. And stage 4 typically treated with palliative intent therapy. There is data to suggest that 75% of non-small cell lung cancer actually present in an unresectable stage, which is either stage 3B or more. This is a very heterogeneous disease, different subtypes of cancers, different biological behaviors, and the treatment remains controversial. One reason for that is the fact that the trials that have been conducted are pretty old. Most of them are small and therefore underpowered to detect small differences. And with the advent of newer imaging modalities, there's a lot of stage migration, and therefore comparison between the results of newer trials with older is fraught with the possibility of there being error. Now, for most locally advanced and early lung cancers, multidisciplinary approach is important. So you need your pulmonologist, you need your radiologist, pathologist, and then obviously you need the cancer surgeon, the medical oncologist, and the radiation oncologist as well. So this is in short the paradigm of treatment for resectable lung cancer. So for most patients who present with stage 1 and stage 2, typically post-mediastinal staging, once you're sure that there's no mediastinal disease, surgery upfront is the treatment of choice, and based on the surgical findings, there's now data for adjuvant chemotherapy as well. For unresectable disease, the standard of care has been chemoradiation. There are a small subset of patients where one can offer neoadjuvant chemotherapy and then going for radiation, but then going for surgery, but then this is mostly an exception rather than the rule. So what are the indications for neoadjuvant induction therapy? I think there's been a lot of discussion amongst lung cancer specialists as to what the appropriate place for neoadjuvant chemotherapy prior to surgery is. I think clearly there's data to suggest that there's no OS advantage in this approach, but still for certain patients where the surgeon is not sure that the disease is resectable, sometimes you'd start with neoadjuvant chemotherapy. For patients with frankly locally advanced disease where the radiation oncologist is not clear if it's safely possible to encompass all the disease in the radiation portal and there's high risk of radiation related toxicities, that's where you sometimes start with neoadjuvant chemotherapy. As I said, borderline resectability, is a setting where most often neoadjuvant chemotherapy is used, but this has to be an exception rather than a rule. Now, while we have data for neoadjuvant chemotherapy, I think there's a lot of interest around the possible role of neoadjuvant immunotherapy as well. Now, this is still within the realms of research. So again, very small studies. One such study you can see on your screen where they've looked at using 2 doses of nivolumab prior to surgical resection, and very small numbers. And then the tumor was resected, and what they were looking at was major pathological response, which was defined as you know uh, no more than 10% of viable tumor cells in the surgical specimen. So initial results show some promise, 45% tumors showing this MPR, and again showing that possibly immunotherapy has some activity in a neoadjuvant setting. But we don't know whether this is associated with any DFS or OS benefit as of now. And this is a subject of a variety of clinical trials, phase 2 and phase 3, where they're evaluating different immunotherapies, either alone or in combination with chemotherapy, or in certain cases, radiation therapy. And they're trying to find out whether this is associated with any advantage in terms of event-free survival or overall survival, or whether in fact in certain cases is actually safe to do that or not. So durvalumab, atezolizumab, nivolumab, all being combined with chemotherapy or given alone prior to surgical resection. And I think we should, in a year or two, start getting some results from these trials. And I think if positive, this will certainly add another other tool for these patients. Again, is there a role for adjuvant chemotherapy in a resectable lung cancer? And the question that they are asking is that, once you've done the resection, and in case adjuvant chemotherapy is done, you've done that, and in case radiation therapy, you've done that as well, whether adding immunotherapy in this subset of patients is going to be beneficial. Now, we do know that there is data for osimertinib in this setting for EGFR positive setting, and therefore these trials are excluding EGFR ALK mutated patients. And again, there are ongoing trials with both nivolumab and pembrolizumab, and I think this is another setting where we will keenly await as to how the results turn out. So what about unresectable locally advanced non-small cell lung cancer? So when we look at the latest edition of AJCC, we know that while most N2, N3 diseases are a part of stage 3, now we also have T4N0 disease and T3N1 disease, which can be included in this. Now, a lot of T3N1 may actually be considered resectable by the surgeons. Similarly, T4N0 in most cases are unresectable, and chemoradiation is the standard modality. Again, what I'm trying to bring out is this is again a very diverse set of diseases which are lumped in stage 3, some of which are resectable, most of which are not unresectable, and therefore treatment modalities may differ. Now, again, in this setting, the question that has been asked is whether addition of induction chemotherapy prior to chemoradiation gives us benefit in comparison to chemoradiation given concurrently. And I think we have data from phase 3 trials to suggest that neoadjuvant chemotherapy does not lead to any advantage in terms of survival, and in fact may add to toxicities with regards to increased rates of pulmonary toxicity and esophagitis, and therefore neoadjuvant chemotherapy prior to chemoradiation is not a standard of care in these settings. So how do we manage these patients? I think for most of these patients, if the disease is unresectable, the standard of treatment is concurrent chemoradiation rather than sequential chemoradiation. There is data to suggest that concurrent chemoradiation is better than radiation and chemotherapy done sequentially, and this is what the standard of care is. Now, there are a variety of regimens that we combine when we look at concurrent chemoradiation. We have the data from various studies which have looked at cisplatin etoposide, cisplatin vinblastine, cispem. I think the two often used regimens are cisplatin etoposide or cisplatin carboplatin paclitaxel. I am aware of a phase 3 study which looked at a combination of concurrent cisplatin etoposide along with radiation versus paclitaxel carboplatin along with radiation. But in the paclicarbo, there were no adjuvant 2 cycles of paclicarbo that we usually do in our clinical practice. And there was a trend towards better overall survival with cisplatin etoposide, but this was not statistically significant. And cisplatin etoposide was actually associated with more esophagitis, while the paclicarbo was actually associated with more radiation pneumonitis. But in my clinical practice, it's easier to combine paclitaxel carboplatin along with radiation. I do see a lot of neutropenia and esophagitis when I have combined cisplatin etoposide along with radiation therapy. So the unfortunate problem with unresectable lung cancer patients treated with CTRT is that only about 15 to 20% actually live up to 5 years. The average survival is still in the range of 28 months, and this continues to be dismal. And various treatment modalities have been evaluated. We have looked at addition of consolidation chemotherapy in the form of docetaxel after completion of concurrent CTRT. Unfortunately, docetaxel added to toxicity but did not add to survival, and therefore this is not a standard of care. We actually also looked at escalating the dosing of radiation therapy from the standard 60 gray to 74 gray. What we have learned is that the higher dose of radiation, especially when you look at the older trials with older radiation modalities, actually associated with more toxicities, more cardiotoxicities, more pneumonitis, which led to greater mortality, and therefore there's no benefit in escalating the dose. And there's been some trials which have looked at adding targeted therapies like cetuximab along with the standard chemotherapy backbone, and unfortunately that has failed as well. And clearly, until the advent of durvalumab, I think most of these patients, despite trying different modalities, would continue to have a poor 5-year survival in the range of 15 to 20%. Now, then we had durvalumab, and we are all aware of what this molecule is and what the data from Pacific is. So I'll quickly recap. We know this is a PDL1 inhibitor, and it is now approved not only by FDA but also by DCGI for treatment of locally advanced unresectable non-small cell lung cancer, where the disease has not progressed following platinum-based chemoradiation. And we have robust data from the Pacific trial. I think in 2017 we have the first PFS data. So we know that patients who have completed concomitant radiation along with chemotherapy with at least 2 cycles of platinum-based chemotherapy and who did not have progressive disease could be randomized between 1 and 42 days to durvalumab, given at a dose of 10 mg per kg for every 2 weeks for a year versus placebo. And the primary endpoint of this trial was progression-free survival. OS was also a co-primary endpoint. And clearly the initial data suggested phenomenal results, a significant improvement in progression-free survival. And we now know that the median PFS with durvalumab is in the range of 17.5 months versus approximately close to 6 months with chemotherapy. And we also saw that in the updated results, the overall survival was also improved by durvalumab given in this setting. And the median OS in the durvalumab subgroup was 49 months compared to 29 months in the placebo arm. So statistically significant improvement in the overall survival in this population of patient. And I think one of the questions that people asked was, what if a patient has had neoadjuvant chemotherapy? And while this was not a stratification factor in the trial, a significant percentage of patients in this trial had neoadjuvant chemotherapy and continued to do well. Now, one of the side effects that we saw, which happened at a slightly higher rate with durvalumab, was radiation-induced pneumonitis and pneumonia. And probably this is where what you use as your concurrent chemotherapy backbone along with radiation is also important. We know that carbopacly anyhow is associated with slightly higher rates of radiation pneumonitis, and therefore probably it's slightly prudent to consider other options, including cisplatin etoposide, when you're looking at doing durvalumab. my own experience with durvalumab has been fairly good, and while the numbers are small and therefore you can't really say that the radiation pneumonitis rates are as high or as low as what the trial has suggested, but it certainly seems feasible even in this setting. Now, unlike the clinical trial, what we see in our clinical practice is that a lot of patients, we may not be able to start durvalumab within the stipulated 6 weeks after completing radiation therapy. And therefore, what is the benefit if you start durvalumab after having completed more than 6 weeks post radiation therapy? And I think this is a pertinent question which has been partly answered by one of this first real life data which came from France. So it included 591 patients in the typical setting where durvalumab would be used, but nearly 40% of patients actually were able to start durvalumab post the 6-week timeline after the conclusion of RT, and a significant number of patients actually showed good response in this setting to durvalumab. So when you look at disease control rate, the CR and PR, so good disease control rate 74% and response rate of 30%, which compares very well to the data that we have from Pacific, where the durvalumab arm were actually associated with 29% survival rate. So clearly suggesting that data from real world shows that even for those patients who cannot start durvalumab within the 42 weeks or 42 days of having completed CTRT, still continue to benefit, and therefore may still continue to be a choice. Again, PDL1 was not a factor. So they looked at a cutoff of 25%, and the drug worked irrespective of PDL1 status, irrespective of age, irrespective of stage and histology. I know some of my colleagues have earlier escalated the fact that EGFR positive patients, the confidence intervals were wide, but again, these are very small numbers, and as per international guidelines, irrespective of EGFR status, you can still use durvalumab and can be offered to all comers. What is important with durvalumab, obviously, is it is reducing the number of recurrences. It also appears to reduce the number of recurrences in brain by nearly 50%. And I think showing that there is some activity within the brain as well. And clearly, I think we know that what the standards of care are for these patients. For stage 1, 2, it is resection followed by adjuvant chemotherapy or adjuvant osimertinib in EGFR positive patient, with radiation limited to those with positive margins, or in exceptional cases with multi-station nodal disease in the mediastinum. CTRT being the standard of care for stage 3. And now we know that durvalumab given post completion of concomitant chemoradiation has led to not only improvement in progression-free survival, but also overall survival. So with that, I'll conclude my talk. Thank you very much, and over to organizers.
Okay, thank you, Dr. Any questions? I'm sure you will be more than happy to answer.
I have a question. Can I ask that?
Yes, please.
Dr. Nitish. So I think Devrat knows where the question is coming from. So he's right in saying that the confidence interval was not the issue. The problem was that in Pacific, only 6% of patients, 92% were EGFR negative. So to my mind, Pacific was actually a trial of EGFR negative patients who were randomized to a post-CTRT immuno versus non-immuno. And to my mind, we do not yet have data on what does the impact of immunotherapy in stage 3 post-CTRT is there or not. And in metastatic, since we are already so wary of it, I was just mentioning to Devrat that we were debating whether we can use this data or not. So I don't think it's applicable. That's my problem.
So can I just ask a question?
Please, sir.
So stage 3, when we don't routinely do an EGFR mutational analysis on these patients. Is it time to do that and segregate EGFR mutation negative, go for the this standard CTRT followed by durvalumab? If it is positive, then probably we'll develop another algorithm after CTRT, maybe the adjuvant TKI or something.
So we don't know. That's where, so 27% patient or 30%, I don't remember exactly. But I know that including EGFR positive and EGFR unknown was 33% or less. So the majority of patients in this trial were EGFR negative, And I am saying that till the data is clear, I am unsure. I'm not saying not. I'm unsure of what to do with this patient. Personally, going by stage 4 data, I'm very reluctant to give them immunotherapy for 1 year.
Exactly. So I think based on the data of the, even the early lung cancers, the adjuvant TKI post chemotherapy, if that can be extended to, and then similarly for stage 4 data, all of them EGFR positive patients, they would respond to TKIs. So stage 3 also would be coming out with something like that, because we have a good number of stage 3 patients.
So we have a study at RGCI.
So there was a CTONG study, which was a Chinese study, which actually looked at this question. And I think, Nitesh, if I'm not wrong, they randomized patients to either gefitinib for a couple of years versus the standard docetaxel-based consolidation therapy. And I think the initial results did suggest that there was a PFS advantage, but I don't think there was a OS difference. But I fully agree with you. I think this is a question which is unanswered. I personally feel that probably there is already osimertinib adjuvant data in stage 1, 2. We know how EGFR has influenced outcomes in
It's
stage
going
4.
on,
I think
actually.
we should be testing.
RGCI has a trial on that.
I think the next speaker is going to dwell on that.
Yes, Dr. Sajjan is going to speak on that only.
Yeah, he's going.
Okay. Any more questions for Dr. Arya? Okay, Dr. Arya, thank you very much for a lucid and clear presentation of indication for durvalumab and how long can we give it. And I hope next time when you tell us, you'll be telling something more in stage 1 and 2 of immunotherapies. Thank you for a lucid talk. Can I request our next speaker, Dr. Surgeon Raj Purohit. Now, from immune checkpoint inhibitors to TKIs in early lung cancer is certainly something a major breakthrough for as far as all medical oncologists are concerned. So let's learn more about it from Dr. Sajjan Raj Purohit, who will tell us clearly when to use it, how to use it, and what are its advantages and survival terms. Dr. Raj Purohit, may I request you? He's a medical oncologist at Max. Yes, Doctor.
Thank you, sir. Yeah, can I have the presentation loaded? Okay, so I'll be speaking on newer paradigms in treatment of resected EGFR mutated early lung cancer. And I think this is one area where we have really made a breakthrough over the last 1 year and being discussed world over. So let me take you through the journey where we are changing the current management for such patients. Next slide, please. So we know that 1 in 3 patients in non-small cell lung cancer, at least in the developed world, is resectable. So lung cancer is the most common cause of death by cancer, and almost 1.7 million deaths annually occur because of the lung cancer, more than all deaths combined by breast, prostate, and colorectal cancers. And among the all lung cancers, 85% patients are non-small cell lung cancer. And among them, 30% patients present with resectable disease. Next slide. Next slide, please. So outcomes of surgery has been the prime stay of treatment for such patients. And for long, we have had adjuvant cisplatin-based treatment for 4 to 6 cycles for all patients from 1B to 3A. And results from large randomized trials and meta-analysis have shown that 5-year OS benefit with adjuvant chemotherapy has been on the tune of 4 to 6%. Overall disease recurrence rates as well as death following surgery with adjuvant chemotherapy regimen has been high across various stages. If you just see stage 1B, the 5-year recurrence rates are 45%, and in stage 3, the recurrence rates are more than 70%. Next slide. So based upon the limited number of studies which were had, which discuss the role of EGFR mutation in the limited disease, the incidence of EGFR mutation positivity has been quite similar to the advanced stage. So if you just see studies across Asia, US, and Europe, if you just see the tune of positivity for EGFR has been roughly around 30 to 40% for Asian population, whereas it has been lesser, around 10 to 20% for Caucasian population. So the EGFR TKIs are available in the setting. A similar proportion of patients will be able to benefit as in the advanced setting. Next slide. So the trial which has been landmark is ADURA, which is osimertinib as adjuvant therapy in patients with 1B to 3A EGFR mutation positive non-small cell lung cancer after complete tumor resection. So this was a multicentric large blinded trial. Next slide, please. So the trial schema was patients with completely resected stage 1B to 3A with or without adjuvant chemotherapy. The inclusion criteria were more than 18 years of age. And for Japan and Taiwan, it was more than 20 years. ECOG performance status is 0 or 1. Patients who had confirmed non-squamous non-small cell lung cancer, either with exon 19 deletion or L858R. Brain imaging, if not complete previously, then at least at the beginning of treatment, and completely resected with negative margins. And the maximum interval between surgery and randomization was 10 weeks without adjuvant chemotherapy and 26 weeks with adjuvant chemotherapy. The stratifications which were used was by stage 1B versus 2 versus 3A, EGFR mutation in the form of DEL19 versus L858R, and race, which was Asian versus non-Asian. Randomization was 1:1 to osimertinib 80 milligram per day to placebo. The sample size was 682. The planned treatment duration was 3 years. Treatment was continued till disease recurrence, treatment completed, or discontinuation criteria met. Follow-up was done until recurrence every week 12, 24, then every 24 weeks to 5 years, and then yearly. And after recurrence, every 24 weeks for 5 years, then yearly. The primary endpoint was disease-free survival by investigator assessment in stage 2, 3A patients. So there was a primary endpoint designed for superiority under the assumed DFS hazard ratio of 0.70. Secondary endpoint was DFS in the overall population, DFS at 2, 3, 4, and 5 years, overall survival, safety, and quality of life. Next slide, please. So the inclusion criteria were adults more than 18 years, non-squamous non-small cell lung cancer 1B to 3A, central confirmation by labs for DEL19 versus L85R, and standard post-operative adjuvant chemotherapy consisting of platinum-based tablet for 4 cycles was allowed, but was not mandatory. Complete surgical resection of primary was warranted, and recovery from resection was allowed, and treatment was to start no earlier than 4 weeks following surgery. MRI or CT scan of the brain was done prior to surgery, and performance status had to be 0 or 1. Exclusion criteria were pre-treatment radiotherapy, pre-treatment or pre-operative chemotherapy, and any other use of any other EGFR TKI or CYP3A4 inhibitors, at least in the subsequent or the preceding 3 weeks. And the time between surgery and randomization had to be 10 weeks, not more than 10 weeks, in when there was no adjuvant chemotherapy, and up to 26 weeks if adjuvant chemotherapy was used. Patients who had only segmentotomies or wedge resections were also excluded. Cardiac criteria that included risk for QTC, prolongation of any arrhythmic events, or any evidence of severe or uncontrolled systemic disease or medical history of interstitial lung disease was taken as exclusion criteria, or any other malignancy. Next slide. So baseline characteristics, if you just see, there was a female preponderance. So almost 70% of patients were females, 30% patients were males. The median age was 60 years. Almost 70% of patients were non-smokers. Most of the patients were, almost 60% patients were Asian, and around 35% patients were non-Asian. ECOG performance was reasonably good. Most of the patients were ECOG 0. Brain imaging was done, and histology was adenocarcinoma in almost more than 96% patients. And among DEL19, 55% patients were DEL19, and L85R was 45%. Adjuvant chemotherapy was received in almost 60% of patients. 40% patients did not receive adjuvant chemotherapy. Next slide. Next slide, please. So the results was for the primary endpoint. Primary endpoint was DFS in the population stage 2 and 3A. So if you just see in the osimertinib arm, it was not reached versus 19.6 months. And the hazard ratio was 0.17, which was highly statistically significant. So we can see there was a very good and a increasing separation of curves between the two arms. And also in the secondary endpoint, which was the overall population, again, the DFS was not reached versus 27.5 months. And this also was hazard ratio was 0.20 and also was statistically very significant. Next slide. So yeah, next slide. Yeah, at 2 year, no, please go to the back, previous slide. Yeah, 2 years DFS was consistent with osimertinib arm across the disease stages. So if you just see by stage 1B, the 2-year disease-free survival was 88% versus 71%. Stage 2, 91 versus 56%, and stage 3, 88 versus 32%. So we could see there was an incremental benefit with the stage at which the drug was given, and all the stages there was a hazard ratio which was highly favoring the osimertinib arm. 0.39 in stage 1B, 0.17 and 0.12 respectively in 2A and 3A. Next slide. So if now we just see the forest plot, and we could see that across all the subtypes, irrespective of the sex, age, smoking history, race, stage, EGFR mutation status, there was a benefit towards use of osimertinib, and this was maintained in all the subgroups. And hazard ratios range between 0.1 to 0.5 across various trials, various subgroups. Next slide. Next slide. So, and the 24-month analysis, at 24 months, there was a difference of around 7% in the overall survival. So it was almost 100% versus 93% in the osimertinib versus placebo. And at this point in time, patients and investigators had remained blinded, but there was a clear early differentiation. That's why blinding was removed beyond this point. Next slide. So there have been trials which have tried to address with other TKIs. So we had SELECT trial, which was erlotinib in the adjuvant setting along with chemo plus RT. And they had shown that there was a meaningful benefit of improvement in DFS. But this is the first trial which has clearly shown in a large cohort that this DFS is highly statistically significant. So we had SELECT trial, RADIANT, EVAN, adjuvant Chinese Tong 1104 trial, as well as BR19, and all had shown prior to this that there was some DFS, as well as there was for example, BR19 did not have any survival or a DFS benefit, but many of these trials had shown that there was a benefit, but then they were not very clear with respect to the trial designs as well as overall population status. Next slide. So this is the first trial which has actually translated into approval for a TKI, EGFR-related TKI in this setting. So what came as a key conclusions were that the type of recurrence also was a key consideration in the resected non-small cell lung cancer patients, and local versus distant recurrence has an impact on the patient outcomes post-surgery, and local or regional recurrences had significantly longer survival compared to distant recurrent patients. And also osimertinib, I'll show in the subsequent slides, that it prevented CNS recurrences, and also this was an important area of unmet need. Next slide. So if you just see the recurrence patterns in the osimertinib versus the placebo, so we could see that among the 11% patients who had a DFS event, the recurrence, almost 62% recurrence was loco-regional recurrence, and only 38% patients who had distant recurrence on osimertinib. Whereas in the placebo arm, comparatively, there were a larger number of recurrences. 46% patients recurred, and in these 46% patients who recurred, 39% patients had loco-regional, whereas 60%, more than almost 60% patients had a metastatic disease, which was a systemic recurrence. Next slide. So this again shows the kind of recurrence pattern. So among all the recurrences, almost 4 times higher chance of recurrence in the placebo arm compared to osimertinib. Lung was the most common site of recurrence. That was a local recurrence site, and the other sites were lymph nodes. CNS, if we just compare, CNS was only 1% compared to 10% in the placebo arm. And again, other sites were also in much higher proportion compared to the osimertinib arm. Next slide. If we just compare the CNS disease-free survival events, in the osimertinib arm, the CNS recurrence only happened in 1%. That means 4 patients compared to 33 patients in the placebo group. So almost 10 times higher chance of CNS recurrence compared to the patients who are in osimertinib. Next slide. So this also shows this, the Kaplan-Meier shows that there was a strong control in the DFS free survival in the CNS, and the patients continue to have no CNS disease at almost 98% patients had no CNS disease at 2 years, and 98% patients had no CNS disease even at 3 years in the osimertinib arm compared to placebo. Next slide. Coming to safety profile, so compared to placebo, almost osimertinib did fairly well, but then they were in almost 20% of patients, there were grade 3 event side effects compared to 14% the placebo arm. And please go to the next slide. I'll show the side effect. Next slide. So the common side effects which were significant were diarrhea. So diarrhea was in 46% of patients. That was, I think, the most common and I would say troublesome side effect, which was with osimertinib, which was diarrhea. Apart from this, paronychia, dry skins, pruritus, stomatitis, and other side effects were there. Diarrhea was one side effect which was troublesome in only 2% of patients, where it led to discontinuation of the drug, which was grade 3 or grade 4. Next slide. Next slide. So coming to the adjuvant chemotherapy use, as I mentioned, almost 60% patients received adjuvant chemotherapy apart from adjuvant osimertinib, and the median cycle was 4. And majority of these patients received platinum-based therapy, and most were in the stage 2 and 3A. 76% patients, only fewer in the stage 1B. Next slide. So if we just see the patient population who received chemotherapy versus no chemotherapy, in the patient who received chemotherapy, the difference was 89% versus 49% in the osimertinib versus placebo arm. Whereas in patients without chemotherapy also, if we see at 2 years, the difference was 89% versus 58%. So there was some additional benefit of chemotherapy in the patients who did not receive any osimertinib. So there was some benefit, but then if you just see the overall population, there was not much significant benefit if this osimertinib was given with or without chemotherapy. Next slide. So if you see, the hazard ratios in patients who were given in stage 2A, 2 and 3A, if you see with chemotherapy, the patient's hazard ratio was 0.14, and patients without chemotherapy hazard ratio was 0.15. So not significant different, though the confidence interval was wider for patients without adjuvant chemotherapy. And this was also in patients where it was all favoring the osimertinib compared to placebo. So a clinically meaningful DFS benefit was seen in osimertinib with or without adjuvant chemotherapy, regardless of the disease state. Next slide. So in stage 1B also, the benefit of osimertinib was significantly higher in the osimertinib arm compared to placebo, and this was maintained irrespective of whether the patient was given chemotherapy or without chemotherapy. Next slide. So these curves again show the same data. Next slide. Yeah, can we skip this slide? This shows that there was a larger benefit. There was a larger benefit in the higher stage. So the incremental benefit of adding osimertinib was seen in patients who were stage 3A. That was the maximum. Quality of life, just last 2 more slides. So quality of life was assessed by SF36, and then it was collected at baseline at 12 weeks, 24 weeks. Next slide. And compared to placebo, the quality of life was maintained and did not deteriorate with osimertinib. Next slide. Also, the time to deterioration of physical as well as mental scores was almost overlapping in both osimertinib versus placebo. That means the addition of osimertinib with chemotherapy or substitution of chemotherapy with osimertinib did not have any detriment on the quality of life indices. Next slide. To summarize, adjuvant osimertinib is the first targeted agent in a global trial to show statistically significant and clinically meaningful improvement in disease-free survival in stage 1B to 3A EGFR mutated non-small cell lung cancer. Overall, there was an 80% reduction in the risk of disease recurrence or death with osimertinib. Osimertinib versus placebo, DFS at 2 years was 89% versus 52%. Adjuvant osimertinib demonstrated clinically meaningful improvement in CNS disease-free survival compared to placebo. The safety profile was consistent with established safety profile of osimertinib, and the mild side effects were noted. And the median duration response to osimertinib was 22 months. Thank you. So I think this shows a clinically meaningful. This shows that with or without chemotherapy, the benefit was maintained, and also the higher chance of recurrence happened in stage 3, where it was more important as an adjuvant arm compared to chemotherapy. And overall quality of life indices was maintained in the adjuvant osimertinib with no clinically meaningful differences versus placebo despite prolonged treatment. So adjuvant osimertinib will provide the new standard of care for our patients who are EGFR mutated positives in 1B to 3A. So this is a new standard of care with this trial.
Thank you, Dr. Sajjan. And if there are any questions for Dr. Sajjan from the audience or from the faculty, he'd be more than welcome to answer this question.
So
any studies on the first generation, first or
Yes,
second generation?
Yeah, so these all studies which I showed in the slide, the SELECT trial, the BR trial, all those are with the
They were non-selected patients.
Yes, sir. Yes, sir. Non-selected patients.
Yeah.
Yes, sir. Non-selected, but not in a way. So this is the first trial which had actual clear selection of the patient population, and I think that's why they could get very good hazard ratios and could get approval.
Is there a difference between DEL-19 and?
So DEL-19 fared better compared to L858R in the DFS.
In this,
in
this study also?
Yes, sir. Yes, sir.
So maybe tomorrow you are going to treat the patients of DEL-19 differently from LSR?
Normally, sir, we have some certain differences when we treat these two patients, but then as of now, we don't really know that whether if there's any other agent which is clearly better to osimertinib even in these two settings. But we know that DEL-19 literally has got a better survival compared to L858R even on this trial and also our trials in the metastatic setting.
Any other questions for Dr. Sajjan, please?
So can I make a quick question? Sajjan,
Sure.
I was seeing a slide on the chemotherapy versus no chemotherapy arm.
Yes,
and
sir.
My interpretation was actually patients on chemotherapy with EGFR did worse.
Yes, sir.
That is why the delta was more. So
yeah, from in some subset there was actually there was a worsening of their DFS when they were given, probably there was more toxicity, or I don't know how there was some interaction which was not favorable with chemotherapy combination. But
which makes it more compelling that if you really have a DEL-19 EGFR, actually it makes it more compelling not to give chemo followed by osimertinib and give osimertinib
first
before chemotherapy. Maybe Dr. Vincent will comment on that. Wait for his opinion on it.
Yeah, we're uncertain at this point in time whether or not these people actually need chemotherapy. You know, I think the standard Canadian answer is do a randomized trial, but I think they should absolutely get the osimertinib, you know, whether they get some chemo or not. I'm a bit worried about the delay in the osimertinib from the chemotherapy. I think that you can give osimertinib at the same time as chemotherapy. That's possible in the metastatic setting. There's some early studies on that. So whether or not they need chemotherapy in the adjuvant setting is an open question. And if they possibly do, could the osimertinib be started concurrently with the chemotherapy? I'm kind of suspecting they may not need chemotherapy at all. That's my suspicion, but I don't know for sure. I think the 858 is a little bit different.
Thank you for that answer.
Thank you, Dr. Surgeon. And now I would invite Dr. Mark Vincent, who will be talking to us in the management of stage 3 non-small cell lung cancer, evidence and experience so far. Dr. Vincent practices in the London Regional Cancer Program and is associated with the Ontario Cancer Care. So Dr. Vincent, he is a well-renowned worker in the field of lung cancer, and I think he'll be delivering us about the stage 3 lung cancer, how to manage it best. Dr. Vincent, please.
Yes, thank you very much. Are you able to hear me satisfactorily?
Yeah, sure.
Yeah, so thank you to the organizers. I appreciate the opportunity. I wish I was with you physically, but maybe in the future we'll see.
Yeah, you have visited us earlier, actually.
Yeah. So I'm going to talk about the stage 3 evidence and experience so far. These are my disclosures. The objectives here to just look a little bit at stage 3 epidemiology, staging, historical overview, what is meant by unresectability, a little bit at the guidelines, just talk a little bit about the importance of the multidisciplinary team, review some chemotherapy very, very briefly, look at the basis for immuno-oncology, and just update some for your overall survival for the Pacific, and just if there's time, give maybe 1, possibly 2 cases. So in terms of the epidemiology, we're essentially dealing here with the stage 3 category. It's a little bit of a heterogeneous category, and I think the survival has varied over time, somewhere between 13 and 36%, but it's about a quarter of the cases maybe worldwide. Here in Canada, possibly even 30%. So it's a significant chunk of the non-small cell lung cancer population. I'm always interested in the epidemiology around the world, and I was able to find this article from Chandigarh, just looking at perhaps your experience and what sort of caseload you would be dealing with. And I'm interested to see that there's a significant number of non-smokers with this disease, even with the stage 3B. And the proportion of squames to non-squames is always a little bit different around the world. I know that this is from Northern India, and that's who I'm speaking to right now, as I understand it. So the staging system keeps on getting updated. This is an ongoing project. I sort of wonder sometimes how much additional value is obtained for people who treat metastatic or advanced disease. I think a lot of it is surgically and anatomically defined. I think the main thing to understand is that there's a new stage 3C category, which is really composed of people with advanced T stage and N3 disease at the same time. And very obviously they would have a worse prognosis. But the essence here really is that even with the stage 3Bs and most of the stage 3As, we'd be talking about non-surgical approaches. So I'm not sure how much additional value carving out this 3C is in terms of the management paradigm. But in any event, we have known for some time that chemotherapy and radiation improves survival over radiotherapy alone. Radiotherapy alone may cure about 5% of these people and is very good for symptoms, but does not really seem to lead to a massive increase in survival, at least from what we can extract from the historical data. But in any event, if you add chemotherapy, initially it was a sequential chemotherapy, there is a definite improvement in survival. In this meta-analysis, it appeared to be quite modest, maybe 4% at 2 years, 2% at 5 years. And we also know since then that concurrent chemotherapy is a bit better than sequential, again, with the difference of about 5 to 5.5% at 3 years and maybe just under 5% at 5 years. But we do know that concurrent chemoradiation imposes logistic problems and increases in toxicity, and it's not always possible. And this is not a very large difference. So up till now, we've been dealing with small incremental benefits in long-term survival. The ESMO practice guidelines do make the specific recommendation that if concurrent chemoradiation is not possible, then sequential chemoradiation is a valid alternative. And we do know that in many parts of the world, concurrent chemoradiation is just not possible. And for that reason, the sequential, I think, is something that can be endorsed. And I would draw your attention to the original sort of pioneering Dillman study that in fact used sequential chemoradiation with vinblastine-based chemotherapy prior to radiation compared to radiation alone, actually showed quite a large increment in survival and long-term survival, pushing the cure rate up to the mid-20s, really, up from below 20%, as well as the median survival. The meta-analysis in 2010 showed there was a benefit of sequential chemoradiation over concurrent, a benefit of the concurrent over sequential. But again, at 5 years, it's perhaps less than 5%. And at that time, the 5-year survival, even from concurrent, was really only about 15%. But we do know there's a price for concurrent chemoradiation, that there's more acute toxicities, in particular, the increased incidence of grade 3 esophagitis, which maybe imposes nutritional challenges to people. It is difficult for elderly people to actually do this. Some people become hospitalized with concurrent chemoradiation. I'm very nervous about doing it in people over the age of 75 or who biologically look like they're over 75, which may be a younger person. So we're sometimes do sequential chemoradiation and with light dose chemotherapy in frail people. And there are quite a lot of frail people with multiple comorbidities who have stage 3 cancer. Now the PROCLAIM looked at a different kind of chemotherapy, pemetrexed-based chemotherapy. This really showed no additional benefit, but it was better tolerated. And for adenocarcinomas, this may be a consideration. This study looked at consolidation docetaxel, which was felt very optimistically was going to improve survival, but unfortunately this was disappointing. It did not improve survival, but it did substantially increase toxicity. What about consolidation platinum after initial platinum? So this is the GILT study, looked at cisplatin vinorelbine compared to best supportive care as a consolidation. And this consolidation platinum vinca alkaloid did not improve survival. The high dose radiotherapy experience was very disappointing. These curves separate early, they separate widely, but unfortunately they're in favor of the standard 60 gray. They're not in favor of the high dose 74 gray. And probably there was some toxic deaths here, possibly related to cardiac deaths and maybe other factors which are perhaps not yet fully understood. But in any event, standard dose radiation remains the standard of care and the standard fractionation, by the way, as well. We do not see, for example, BID fractionation as explored and may possibly arguably be a standard of care in some places with limited disease small cell lung cancer. This has not been established in non-small cell. The addition of cetuximab did not show any improvement. The addition of gefitinib, EGFR TKI was actually detrimental, and these are non-selected patients. These are not patients necessarily with the EGFR mutations. The EGFR mutation studies are still in process with osimertinib in the stage 3 setting. So this is our experience here in London, Ontario, Canada. We went through a phase where etoposide was expensive and difficult to obtain about 25 to 30 years ago. So we treated 300 patients with a vinca alkaloid, vinblastine-based treatment, cisplatinum, fairly high doses, both induction, 2 cycles and 2 cycles concurrent. And we obtained fairly comparable data to anything that was then current with etoposide, that in the patients who were fit enough and could get the full dose of both the platinum and the radiation therapy, that their median survival was about 24 months. And there was a long-term survival of about 20–25% in these patients. But we do know certainly that people who cannot get the full dose platinum or who cannot get the full doses of radiation therapy did worse. This was by no means a randomized trial. This is just a one institute experience over about a 10-year period. But this is about 300 patients. And it does show that vinca alkaloids are acceptable if etoposide is difficult to get. But during the radiation therapy, you do have to reduce the dose of the vinca alkaloid. And for that reason, we feel it's not really optimal. It's probably reasonable to go with the platinum etoposide and only the 2 cycles during the radiation. And that's our current standard of care. Occasionally, people will use carboplatin and paclitaxel in more frail patients on a weekly basis without consolidation or induction. Our radiotherapists are a bit concerned here about the radiotoxicity with taxanes and favor us using etoposide rather than the taxanes. So I just want to talk a little bit about resectability and unresectability. This has been argued, and it is controversial. In the United Kingdom, this study was put out, Everson et al. On behalf of AstraZeneca, actually, which had a fairly liberal interpretation and suggested that in certain cases you could resect multi-station N2 as long as it was pathologically confirmed. There was thorough staging, including pathologic staging, that you felt that you could get clear margins and you could complete and do an R0 resection, and that the nodes were basically less than 3 centimeters. However, another UK publication was put out saying that really, no, you shouldn't be resecting multi-stage N2 disease. You should really only be resecting in a very selected patients with single-stationed N2. And it's okay if you do see nodal disease in the N2 in the mediastinum when you think it's stage 1, 2. At that point, you're in the chest already. It's probably reasonable to do it. But otherwise, if you know beforehand that you're dealing with multi-station or large, bulky nodal disease, you should not resect them. So there's a little bit of controversy even amongst the surgical community. So what about the randomized data? So here's the EORTC 08941 study, which looked at, started out with nearly 600 patients. They then gave them induction chemotherapy. And if they managed to come through the induction chemotherapy, they were then randomized to either surgery or radiation. There's about 165 patients in each arm. And basically this, the hypothesis here was that surgery was superior to radiotherapy, but in fact, it turns out it is not. The radiotherapy alone was as good as surgery in this study. This is, next study is an INT0139 study. It was a very famous study. There was some Canadian participation in the study. And this was, again, pathologically shown N2 disease. About 430 patients were randomized to getting platinum etoposide for 2 cycles with concurrent radiation, but only to 45 gray. So everybody got that. And then at that point, they were restaged. The radiotherapy was stopped for a short time. And then they were either randomized either to the surgery or to the radiotherapy arm. And actually, there was a pre-randomization, but basically, they all went through the platinum etoposide and 45 gray and then were restaged. And if they had no progressive disease at that point, they went on to their pre-assigned randomization arm, which is either surgery or to complete the radiation to 61 gray. So the radiotherapists we know don't like to do this. They don't like to stop the radiotherapy, and they particularly don't like to stop the radiotherapy for unsuccessful surgery. But in any event, if they were fit enough, they then got 2 cycles of consolidation platinum etoposide afterwards, which we know is probably not of any value. When you looked at the overall survival here by the intent to treat here, there was no difference, but you do see that these curves cross, and the radiotherapy arm alone is favored in the first half of the curve, but in the second half of the curve, there's a bit of a breakout that may indicate that some people with surgery may benefit in addition. So this is not pure surgery. This is incomplete radiation followed by surgery. Now, they then published what is really, in fact, speculative data and what people think is real data. The yellow arm that you can see there, the yellow curve there is, in fact, real data. It's about real survival with the chemotherapy, radiation, and surgery arm. On the left, you see the patients who got lobectomy. On the right, you see the patients who got pneumonectomy. So unsurprisingly, the pneumonectomy patients, if you just look at the yellow versus yellow curves, the pneumonectomy patients had higher stage and worse disease, and you'd expect them to do worse, and they do. But the blue curves are hypothetical curves for the radiation alone. The blue curve people did not get surgery, but there was an assessment made that some people would have got lobectomy. That's the blue curve on the left. And some people would have got pneumonectomy. That's the blue curve on the right. And this is speculative data. These are not people who actually got this. Blue curve is the radiation alone arm. And the idea that they're trying to propose here is that if they would have got lobectomy, you have an advantage from surgery. If they would have got pneumonectomy, there's actually a disadvantage from surgery, probably related to overflow pulmonary edema. And I've seen that, and it's terrible, and you can't get them out of it. So the idea here is that if you can get away with lobectomy, maybe you could do it. If you can't, you shouldn't. So that was the sort of conclusion and the message from this study. But if you look at the top table here, what you see, in fact, that even in the arm that got surgery, that most of the recurrences, about 48%, compared to only about 10%, most of the recurrences are metastatic. And certainly in the no surgery arm, you see the same sort of thing. So the idea here, actually, what the study really showed is that surgery does not save you from metastatic recurrence. That most of the recurrences are metastatic, even in single station N2, and I'll show you some data. But in the durvalumab study, the Pacific study, you got reductions in both local benefit was improved by durvalumab, but also there were reductions in the metastatic failure in brain, in liver, in a bone, adrenal, that the durvalumab protected patients, not completely, but to a very substantial extent, from metastatic recurrence, as well as from local recurrence. Whereas if you get to successful surgery, there is no doubt that it does protect you to some extent from local recurrence, but it does not really protect you from systemic recurrence because there's no significant difference in the systemic failure rate, even though there is some benefit with respect to local control. Whereas if you look at the Pacific study down here on the left, there's benefit with respect to both local failure and systemic failure. It's a very important point I want to make. Now, if we look at further meta-analyses and Japanese experience, basically from their experience, single station N2 surgery is certainly better than multiple N2 when they do resection. Multiple N2 surgery does very, very poorly. It's less than 20% long-term survival. But single station N2 doesn't do that great. It's really only about a 42% long-term survival. That means most people are dying, and they're dying of metastatic disease. What may be acceptable is if you have a single station N2 node in the upper mediastinum, that may be more acceptable. But it's certainly in the lower mediastinum or multi-station N2 disease do very, very poorly on surgery. This is unacceptable really now. And even if you have a single node in the upper mediastinum, if this was breast cancer, this would not be acceptable. If it was breast cancer, it absolutely would not be acceptable. So the NCCN has weighed in on this with guidelines. And what they have said is that for T1, T2 with N2 disease, the category 1 recommendation now is combined concurrent chemoradiation. And we know that sometimes you have to do sequential with durvalumab. But they do put out their surgery in certain selected cases by negotiation and so on. But the category 1 recommendation is combined concurrent chemo and durvalumab. But it's certainly durvalumab with chemo and radiation. In these patients with big primary tumors, T3, T4, but a low nodal burden, you know, it's arguable, and you have to go to the MDT really to decide what to do. But in the stage 3B and stage 3C, or these big tumors with N3 disease, it absolutely, surgery is contraindicated, and it's chemoradiation and durvalumab. The NCCN also, just notably here, does not recommend surgery for any N2 disease, and just goes through a range of chemotherapies that could be possible. They're all platinum doublets, and basically there's a fairly liberal interpretation, platinum vinblastine, paclitaxel carboplatin, or platinum pemetrexed, and I'm sure you're all familiar with that and have your own particular chemotherapy flavor. Just to note again that there are certain chemotherapies that you cannot give at full dose during radiation. You probably shouldn't give gemcitabine at all during radiation. Docetaxel is difficult to give with radiation. We have done it. It's very effective, but it's quite toxic, and you really probably shouldn't do it other than on a clinical trial concurrently. If you give vinblastine, you have to dose reduce during the radiation, and for that reason, you should probably give some induction at full dose. So it depends on access and all sorts of factors that I'll leave to your discretion. The ESMO does indicate that if you have unforeseen N2, you think it's stage 1, 2, adjuvant radiation is good. If there is unresectable N2, It's non-surgical management. If it's potentially resectable, it should be discussed at a multidisciplinary team. That's what the ESMO have suggested. So in my opinion, surgery now has a very restricted role in N2 in stage 3. Medically unfit patients shouldn't get it. Pneumonectomy is a contraindication. T4 or N3 are absolute contraindications, except some N0 or maybe some N1, very selected patients. Bulky N2, multi-station N2, and N2 with extracapsular extension are contraindications to surgery. T3, N1 may be considered for surgery if you can get away with a lobectomy. And N2 is generally a contraindication to surgery, except if single station and incidental or upper mediastinum, and only then if you can get away with a lobectomy. But in my country, if you do surgery, you lose access to durvalumab from a funding point of view. So in my country here, it's a hard choice between surgery and durvalumab. And so I think at the very least, patients need to be thoroughly informed about the benefits of durvalumab if they are being offered surgery. And this needs to be discussed by a multidisciplinary team. Now, this is a very interesting study from Korea where they did 570 N2 cases. 3/4 of them were single station node. They had neoadjuvant concurrent chemoradiation followed by surgery. What they found actually was that 70% of these patients recurred despite the surgery. And almost all of the recurrences, except for about 10%, were metastatic. And by 5 years, 70% had recurred despite the surgery, And most of the recurrences occur in about 18 to 24 months. So again, in this meticulously managed group of patients, South Korea, trimodality therapy, most of them recur, and most recur in metastatic sites. So really, the bottom line now, unfortunately, is that even though surgery is technically feasible, it's really closing the barn door after the horse has bolted in the majority of cases. Sure, there are a few cases. Sure, there's a local control benefit. Sure, it's technically possible by highly skilled people. But unfortunately, this is a systemic disease in many, many cases, just like we understood from breast cancer a long time ago, and stopped doing super radical mastectomies. It's the same thing now in stage 3. So really, if you're a surgeon, the main idea, and I'm speaking here with all respect, we work very closely with very good surgeons. They ask themselves, can I get an R0 resection? And in some cases, it's technically possible. A stage 1, stage 2, it's technically possible. But you've got to ask yourself, not only is it technically possible, the real question is, what is the chance of a surgical cure? So in multi-station N2, lower mediastinum, in these rare stage 3Bs that can be operated on, the chances of a surgical cure are low to 0. So even if you can do it, it doesn't mean you should do it. But I do accept that there are cases where it is controversial. But most stage 3, even if you can do it, surgery is probably not the way to go, especially if you lose access to funding the immunotherapy. So the MDT, I'll just say, just the virtues of the MDT. Stage 3 is quite common. It's heterogeneous. It requires sophisticated staging. The management is often debatable. It's a rapidly evolving field, and the stakes are high because cure is possible. It's been mandated here in London, in Ontario, and in Canada by our parent organization, Cancer Care Ontario. It's required for accreditation. It's standard of care in the United States and Europe increasingly. We meet once a week for an hour. We take minutes. The chairmanship is rotated amongst the various subdisciplines. We try to have diagnostic radiologists always, pathologists, pharmacy, respirologists if we can, trainees. Attendance for trainees is mandatory. It's a fantastic forum for training. It's been endorsed by NICE in the United Kingdom. They do point out there are certain problems. You shouldn't use this as a way to delay patient management, for example. It's required by health authorities for accreditation purposes now in multiple countries. And you should communicate the deliberations of the MDT, particularly to the family practitioner. There are phases in this journey. There's the diagnostic and pre-treatment evaluation, and that can be beneficially impacted by the MDT. There's the treatment decision and plan, which I think is very important with the MDT. And then there's the treatment itself, the administration, and then the long-term follow-up. And that's perhaps less important to bring back to the MDT. But this diagnostic process and the planning may be critical unless it's absolutely obvious. We cannot discuss every single patient with stage 3. We try to do it, but we cannot. So we do it in selected patients. And I think that's probably what most people do. Patients presented on MDTs are more likely to get guideline concordant treatment. There's all kinds of advantages, management of complex patients. There's collegiality, maintenance of high treatment standards, job satisfaction, reducing inequities to access and so on. But there is the potential for delay, and there's going to be conflict. There's going to be difference of opinion. And I think you have to have a mature, experienced clinician to manage this process, because there's going to be conflict. There's going to be that sort of thing. The other thing that's critical is the availability and use of technology, especially in the era of COVID, where people are trying to connect remotely. The technology has to work. It has to work every time, and it has to work perfectly. So what I've personally learned is collegiality. It's a great forum for that. No one has all the answers. You need an efficient secretary. The technology has to be good. You should include pathologists, radiologists, and pharmacists. Most people are just trying to do their best. We live in different worlds, surgeons, radiotherapists, medical oncologists. These worlds don't necessarily overlap. Most different specialties are exposed to different data. It's important for payers to align incentives. If you get payers highly incentivize people to do surgery all the time, you're going to get what you incentivize. So the payers have to understand how to structure the incentives that are concordant with modern data. And that's critically important. It's different in every country, of course. If you open your mind, you'll always be educated by your colleagues and by the cases. And medicine is a lifelong experience of education. And the other thing is that if specialists know they're speaking in front of their peers, they're more likely to stay current. Now, in the UK, I'll just say that a lot of people in stage 3, 3A and 3B is blue and gray. They don't get anything. They just get best supportive care. In the UK, only about 12–11% of patients get radical chemotherapy and radiation with stage 3. So we know there's a lot of work to be done about access. Now, the rationale for immunotherapy, we know there's the cancer immunity cycle about antigen release, processing by dendritic cells going to the lymph node. There's a checkpoint of CTLA-4 in the lymph node. If they get through that, they get into the circulation. There's another checkpoint, PD-PD-L1, in the tumor, and that can switch off and cause lymphocyte exhaustion and death. But we know that some of these problems are overcome by concurrent radiotherapy or radiotherapy just before the immuno, with all sorts of alterations in the tumor and secretion of danger signals and cytokines and so-called immunogenic cell death. And also with concurrent chemotherapy, with the radiation, you do get these signals, even like ATP and calretilin and HMGB1, that can help to mature the dendritic cells to present the antigen to the lymphocytes, to mature the T cells appropriately, and to get the T cells back to do the business of killing the tumor. But we know that PD-L1 is one of the things that's upregulated by radiation, which is why the baseline PD-L1 may be completely unreliable. And that this is an obstacle. The PD-L1 is a don't eat me, switch off signal to the T cells, and it needs to be blocked. And one way to block it is with an anti-PD-L1 antibody on the tumor cell. But PD-L1 is also there on macrophages, by the way. And that also needs to be blocked, because those are the tumor suppressive, immunosuppressive macrophages. All of this has been worked out by these two individuals, Dr. Allison, Dr. Honjo, who were jointly awarded a Nobel Prize, and rightly so. Now, what is the data that makes us so interested and excited about this? This is the Pacific study, which randomized patients 1 to 42 days after chemoradiation to durvalumab versus placebo. The durvalumab 10 mg per kg every 2 weeks for a year. That's debatable, but we'll see. And this showed a massive increase in survival. And this is the 4-year update of survival, showing the curve separate early they never come together. We have hard data out now to 4 years, showing actually about a 13.3% absolute increase in survival. That means for every 7 patients exposed to this, you are going to get long-term survival in one of them, and it may be a cure. And we have not seen this kind of improvement in stage 3 lung cancer since the Dillman study in 1990. So this is a breakthrough not only in oncology, this is a breakthrough in medicine and in science. And this is the updated progression-free survival. And we see at 4 years, there is about a 14–15% increase in progression-free survival. And these curves are getting flat. And really that means that these people are probably not dying from lung cancer. Of course, many of these people are older and they may be dying from other comorbidities. And this shows us that the progression-free survival really is equal, more or less beneficial, both in people over the age of 70 and people under the age of 70, so that age itself is not an impediment to this, and that the toxicity here basically shows that this is very acceptable treatment in the vast majority of patients. Now, you do have to be careful. You know, patients with autoimmune diseases, it's a bit controversial. You have to be careful. I have done it here with an autoimmune disease, ulcerative colitis. I've done it safely, but it was a long discussion and careful monitoring. The pneumonitis risk, it's there, but it's modest, and it is much less than we thought it would be. So the toxicity and tolerability of this treatment, by and large, is acceptable. And we see that both smokers and, curiously, non-smokers benefited, PFS and overall, with a 95% confidence not crossing 0, that the benefit is mainly and more in the patients who get baseline cisplatin and not carbo, interestingly. But I mean, the benefit is there for carboplatin, but the benefit is more with cisplatin, interestingly. And the EGFR, I know that we've had a discussion about this. You know, there's not that many patients, and it does cross 1, and we don't even have the survival. But I will say the non-smokers do benefit. The non-smokers benefit, and some of them will have been EGFR. So I know that's still an open discussion. We now have 5 pillars of management: surgery, radiation, chemo, targeted therapy, and immunotherapy. So we're in a new era here. So I think in the remaining minutes, and I'm going to be guided here by the chairman, I'm just going to go through at least one case, and if there's time, 2 at your discretion. So this is a 65-year-old man who presents with a dry cough and shortness of breath. He's a 75 pack year smoker, but he quit a long time ago. Really, he's got a bit of hypertension, bit of hearing loss, and he does wear hearing aids. He's a bit of an obese person. You can see that there's a lesion in the left upper lobe there. That would be easily missed on a routine, but the left lung is kind of hazy. And on the lateral, you can see the diaphragm. There's something wrong with the diaphragms here, but on the CAT scan, you see the spiculated left upper lobe mass, 2.5 centimeters. He's got a big paratracheal node, probably another one there in this sort of aortopulmonary area. And he has an EBUS. And basically this large 4L node is easily visualized and biopsied. He also has a node that's a left hilum is visualized, but not biopsied. This is an adenocarcinoma, TTF1 positive. We sent it off for next generation sequencing. He's actually got a BRAF mutation, a variant of unknown significance, and we decide to ignore that. We don't have a treatment for it right now, so we just park that to the side. He gets referred to the MDT. The MDT says this is great, but you know what? His staging is incomplete. He needs an MR of his head and a PET CT. We like to do that if we can. Not everybody has access, and he needs pulmonary function test. He has his head scan, it's fine. He has his PET scan, that's the primary tumor. He has the 4L node, but he has this other node here as well, which is also hot. So this gentleman basically has multi-station N2 disease. He's ECOG1, really T1, CT, and N2. He's offered a combination of concurrent chemoradiation. Surgery he has definitely off the table. Radical curative intent radiation, 60 gray and 30. But because of his hearing loss, we avoid cisplatin and go with carboplatin and pemetrexed concurrent with the start of radiation therapy. This is partway through. After 1 cycle, it's starting to improve, minimal toxicity. This is after the 3rd cycle. I actually had 3 cycles of carbo pemetrexed concurrent with the radiation. And you see an improvement there, fairly substantial, and you see it more on the lateral. And the CT scan, they're going this way now. You see that there's an improvement. It's still there, however, it's not gone. The node, however, is much better, but it's still there. He commences durvalumab, and we do a 20 mg per kilogram monthly. And he continues now, starts on the durvalumab. The lesions actually get smaller. They get smaller on the durvalumab, and that's an interesting point because that happens more on durvalumab than on surveillance. And the nodes are getting smaller, the primary lesions getting smaller. There's no evidence of pneumonitis until about 3 months into it. He starts to get a cough and shortness of breath, and we felt that he had some pneumonitis both in the radiation field and also outside. So at that point, we decided to hold the durvalumab. We gave him prednisone 75 milligrams a day, and we weaned it slowly over 6 weeks. The other thing we did was that he stopped his Covasil, which he had for hypertension. This is perindopril. It is an ACE inhibitor, and it also causes cough in some people. And so basically we have on the 5th of August, his cough is much better. The pneumonitis outside the radiation field is cleared. He's got a bit of stuff here, which is probably from the radiation. We decide to restart the durvalumab, and he's able to finish the full 12 months course of it once a month. At the end of it, he's much less dyspneic. Now that the CT scan has changed, really it's hard to say there's a viable tumor in there. It looks like a radiation field. The node is kind of almost gone, and he's feeling fine. And basically our plan now is just to go with surveillance with this individual for the next 3 years. There obviously are a range of toxicities that can occur with durvalumab. There are a range of toxicities. Probably the most important one is pneumonitis. If you use this drug, you need to know how to manage side effects, and I'm sure you do, but your colleagues in the emergency room, in the small peripheral hospitals, may not know how to do it. And so it's really important to communicate with anybody who may be seeing these patients in follow-up or during the durvalumab about how to manage especially pneumonitis and any of these other things. Communication, steroids, it depends on the grades of toxicity. You know, mild steroids hold the drug. It's a bit more severe. Maybe it's methylprednisolone, 1 to 2 mg per kilogram daily for a couple of days till it gets under control. And even infliximab, which is expensive and may not be available. So toxicity in our experience here is rare, but you do need to be able to manage it. And of course, it's in the context of immunotherapy in the stage 4 setting. So these people need to be managed out in the district, even with stage 4. So there's a massive need for education here. Now I'm at the chairman's discretion. I'm on time. I can show a short case here, or I can stop at this point. It's up to you.
Please go ahead, Dr. Mark.
Thank you. So case number 2, here's a 70-year-old female, smoked a pack a day, probably since she was 10 years old. Chest X-ray reveals an obvious abnormality in the left hemithorax. You can see she's got COPD, but there's a large round mass adjacent to the left hilum. You can see it's posterior on the lateral. It's a posterior mass, probably in the upper segment of the left lower lobe, but possibly crossing the fissure. So she proceeds to a CT pulmonary angiogram now because she's got chest pain and a bit of shortness. They thought she might have had a PE. So you see all the CT pulmonary angiogram, but she does have this very large mass here, which is 7.1 centimeters actually, and is felt to cross the fissure. And there may in fact be some mediastinal nodes. They're suspicious, kind of difficult because it's all socked into this big mass here. It's followed by a PET scan. Here's the PET scan. It shows that some of this is necrotic, but there's a ridge of activity here, and the sort of mediastinal nodes are sort of buried in this mass, but the one of the N2 nodes was very suspicious and somewhat hot. So this was felt to be certainly a stage 3, and she proceeded to a transthoracic biopsy. The MR brain was negative, and this is what the pathology showed us here. Sheets of poorly differentiated cells. It is felt to be an adenocarcinoma, abundant mitotic figures. Negative for TTF1, by the way, I will say that, but felt to be an adenocarcinoma. It's P53 mutated. We can't target that. And the EGFR and ALK were negative, but she was strongly PD-L1 positive, as it happens. Not a surprise. She's a heavy smoker. The pulmonary function tests were borderline, as you can appreciate from the chest X-ray in general. The FEV1 is 64%, the DLCO 40%. The final stage was T3 and 2. But by the eighth edition, this is more than 7 centimeters and maybe a T4. But in any event, this was felt to be obviously inoperable for multiple reasons. Surgery refers to medonc. She has some hemoptysis. She's quit smoking. She's ECOG 0, interestingly. She's thin but not emaciated. Her creatinine's low because of low muscle mass, but her albumin was okay at 39. She wanted to be treated aggressively. She had a great grandchild on the way. She wanted to live to see this baby born. We felt she was kind of borderline, but okay to go with combined concurrent. But we decided to offer an induction cycle of cisplatin etoposide under the cover of GCSF. We counseled her at the time about development, so it wouldn't be a shock. She has this pain. She didn't want to go on narcotics, interestingly. She said, no, I'm okay with Advil, which is ibuprofen. I'm going to stick on my ibuprofen. Thanks very much. So she gets 1 cycle of induction platinum etoposide. She gets a bit of tinnitus. That's worrying her a little bit. Blood count drops, but her counts are okay. And there's a little bit of improvement. You can see it more easily on the lateral, which I haven't showed you. But on cycle 2, she commences at the same time now as radiation. But we changed to carboplatin. We reduced the dose by 20%, no GCSF because it's concurrent, and she commences radical intent radiation. But now something happens. Something happens, okay? And you can see below the diaphragm, you can clearly see she's had a perforation. She's only now partway through the therapy. She's only just kind of a week or 2 into the radiation therapy. And she's been taking a lot of ibuprofen. And we think that's probably with the steroids, with the chemo, that's what popped. And she went on to have surgery. There's a CAT scan. She's a duodenal ulcer. She's patched. She comes out of surgery. She's on antibiotics. She's in intensive care for 2 weeks. She had pleural effusion. It's negative. It's drained. And we have to think what to do. We decide no more chemo. But even with ECOG 3, she wants to finish the radiotherapy. She gets on with radiotherapy. It's kind of completed and it's responded. And at that point, a lot of lessons here, but we decide to go ahead with the development at her request. She's now had 3 cycles of development, 3 months of development monthly. She's continuing to put on weight. She's doing well. She's cheerful. She's happy. And she's on her way to see this great grandchild being born. So the message is, this is not quite sequential, but it's a kind of sequential situation. In a frail patient, she was able to get to the development and to tolerate it, and she's doing well now. I'm going to finish off here just basically to show that essentially sequential versus concurrent in a Canadian retrospective was not significant in a multivariate analysis. And basically either is possible. There's studies now with development, both in concurrent and in sequential. This data is coming. This is the Pacific R study, and the Pacific 6 study has some patients with sequential, and we're going to get some data. And with that, I'll thank you for your attention.
Okay, thank you, Dr. Mark. I think it was very, very interesting and illuminating how to manage really stage 3 lung cancer. I think we already had enough complexities with chemo, radiation surgery, and immunotherapies, and TKIs adding into it has made it more compound. So the talk is open for discussions, and any questions to Dr. Mark, please.
Can I start with a very simple question, Dr. Vincent? In your setup at the moment, who do you give neoadjuvant chemotherapy to based on the fantastic discussion that you put in front of us? So
usually the surgeons will phone us up because a lot of our patients do come through the surgeons for biopsy and mediastinoscopy, or just workup initial, and they do want to operate. There's no question, they do want to operate, and they say, can you give some neoadjuvant chemotherapy? I just shrink it a little bit to get it off the pleura, to get it off the aorta or something, they know that chemotherapy is quite effective in doing this in a number of patients. So we will do it in people who are sort of borderline resectable, and where it's just a question of shrinking the tumor off some kind of structure that's making it a bit easier. But, the more controversial ones are
That's still a N0.
worry that you can't do a surgical properly, and then you don't have radiation and so on. So there's those patients we funnel into them MDT.
So you're saying it's more of a T question than a N question. If you've got
Yeah.
actually more than N1, you just don't take them up for any.
No, it's the borderline T. It's the borderline primary tumor situations. Yeah.
Okay. Thank you very much for that.
Dr. Mark, I have one question for you, please. My question is, in the stage 3 lung cancer, we will be having, it's a wide group of disease, stage 3 in itself, categories you could say. If some of them are both EGFR positive,
Yeah.
would it be suitable to give them durvalumab or osimertinib? What is your kind opinion on this, sir?
Well, you know, one of the interesting things is whether you should give them osimertinib up front. You know, I mean, you want to start protecting the brain. What worries me about EGFR mutated lung is the high incidence of brain metastases in these patients. And why shouldn't you start to protect the brain immediately? So the way I predict it will be to go maybe concurrent chemo and osimertinib at the same time, maybe with an intercalated kind of approach, but I think together, and then, you know, a discussion about what happens after they've had maybe 2 cycles of chemo and some osimertinib, and how much is it shrunk at that point? Is it a surgical thing, or is it a chemo radiation stage 3? And then I actually think, given the very, very good results of ADAURA, that they will be on osimertinib subsequently for 3 years. And I think that the number of patients with EGFR mutations in the stage 3 study, in the Pacific study, was probably too small to make definitive conclusions. And that probably the magnitude of benefit will be better with osimertinib for 3 years. But I know that study is in process after stage 3 with the osimertinib. But I even think that induction osimertinib may be a very, very smart thing to do before you do the definitive local treatment, whether it's surgery or radiation. I mean, most patients in the Western world with EGFR are stage 4. Most patients are stage 4. So we don't have many stage 1, 2, 3 patients who are EGFR mutated. We do see them occasionally, but the overwhelming majority of EGFR mutated patients are stage 4. It may be different in your country.
Dr. HP, can I ask a question? Dr. Sham this side.
Sir, all yours, sir. All yours, please, sir.
Good evening, Dr. Vincent. I had a patient today. This patient is, 50 years old, and there's a 5-centimeter mass, which is, pleura-based and is actually infiltrating the 5th and 6th rib, and also maybe the chest wall. And there is a small internal mammary node. So what do you think should be the approach here? My surgeon is very keen to operate.
Yeah. I think there's a substantial possibility that the mediastinum is contaminated. But our surgeons here would probably operate. But this is one of the ones where they'd say to me, maybe not go to the MDT. Can you give 2 cycles of induction chemotherapy here first? And then do a chest wall resection. But the real question is, if you're going to end up here, it sounds like you could end up here with a pneumonectomy potentially, which would be a contraindication to radiotherapy. So we have seen people who've had pneumonectomies get radiated, and they very, very, very easily go into pulmonary edema because the entire cardiac output is now going into one lung, and the lymphatics coming out of it have been irradiated in the mediastinum. These people can tip into pulmonary edema very, very easily, and you cannot get them out. And I've personally seen 2 people die like this. So I would say, the mediastinum, you just may have to take your luck here, but probably chemotherapy, surgery, wedge, and maybe a pneumonectomy, how they're going to do the mediastinum. If they stay away from the mediastinum and just do a wedge, then you might consider with your radiotherapy colleagues whether you could irradiate the mediastinum safely. So it may depend on the extent of the surgery. If they do a pneumonectomy, I think radiation is not a good idea, either before or after, but you should have some chemo. Yeah, they can do chest wall resections. They can do them quite skillfully.
Thank you very much, sir.
Any more question, please, from the audience or the honorable speakers? Dr. Mark, if I may ask one more question to you, sir.
Sure.
You've told us about EGFR, you've told us about durvalumab. Are there any studies, we know lung cancer got a host of mutations. We got the ALK, the ROS, the BRAFs, and the HER2s. Is the adjuvant therapies also going to be different for these kind of subsets?
Yeah.
Or what's your opinion, sir?
So I hope that the ADORA study is going to lead to adjuvant studies in these targeted treatments. But of course, the problem is going to be, number one, the expense. And number two, how common are these patients to do randomized trials? And so, we have a very conservative payer system here where the government is paying. And they generally want level 1 evidence with survival benefits before they will write a big check for 3 years of targeted treatment. So ALK in our population is only about 2 to 3%. ROS1 is about 2%, and the rest of them are less than 1%, or maybe 1 or 2% BRAF. So the real question is going to be, are there enough patients to do decent sized randomized trials that are adequately powered to show a difference? The one thing I would say about the ADORA study is that I think it was overpowered for the effect they got. They'd probably have got a p-value, with even a much smaller study, but they didn't know that, of course. They didn't know that up front. But it may be the case that with an ALK inhibitor, for example, you could get by with a much smaller randomized trial if you think you're going to get a big effect like this. And I predict you would get a big effect, like you do in ADORA with the targeted treatment. If I have somebody who walks through the door and has had a surgical resection of an ALK positive cancer and is worried about the recurrence, I would be very, very concerned. And I would discuss with them, whether if they can afford, if they can pay for an ALK inhibitor, it's a conversation you should have, but certainly my system won't pay for it without some kind of randomized trial.
Thank you, sir.
And I think it would have to be a worldwide effort, to get as many of these patients around the world in a very coordinated way. Big, strong pharmaceutical companies, probably the only way it's going to happen.
True, sir. Thank you. Any more questions, please? Okay, thank you, Dr. Mark, for an excellent talk on stage 3 lung cancer. I never knew it was so complicated to look into such finer aspects of upper and lower mediastinal nodes. So that was very, very good information for all of us to gather. Thank you once again, sir. And with this, we now go on to the next session. May I request Dr. Dowell to kindly call the next speakers and his panelist for the next topic. Thank you, Dr. Mark.
Thank you.
Rangarao.
All the best. Keep safe.
Okay, thank you. I would invite Dr. Rangarao now, who is the chairman of the SPARSSH Cancer Center Group, and he'll be holding a panel discussion. Dr. Rangarao, please.
Yeah, thank you very much, sir. So I will start with inviting the panelists. So first panelist is Dr. Mark Vincent. May I request you, Dr. Vincent, to join us for this? Dr. Nitesh Rothgi, Dr. Manish Kumar, and Dr. Dr. Manish Singhal, and Dr. Darlong, and Dr. Shubham Garg. So we have 2 surgeons, and then we have 4 medical oncologists. We don't have any radiation oncologists, right? Okay.
So we have Dr. Puneet as radiation oncologist, and we also have Dr. Manish Singhal now on the panel, sir.
Right. Okay.
And Dr. Batra would be joining in another 5-10 minutes, sir. He's getting late, so
we must be still in the flight from that place.
Yeah.
All right. So let me start with my slides, and actually my discussion, I'll cut it short as much as possible because a lot of things have already been discussed. So do I have the slide sharing facility? Yes. So, so welcome to this panel discussion. It will be purely case-based, and I won't be doing any theory discussion. And then we all know that it's a very heterogeneous disease. That's what Dr. HP was also saying. It's so heterogeneous that we were unable to comprehend the kind of a heterogeneity that this stage 3 has. And I don't know why they have put it as stage 3, A, B, C, though they have made it. I think that's a very, very complicated thing. Right. And then this is just to say that most of them would have the unresectable tumors, and then they would go for either concurrent CT-RT or the neoadjuvant followed by this thing. And we all now have realized one thing, that both local regional control and the systemic control is important, and then brain is a sanctuary site for metastasis. So therefore we need to see that they don't have the metastasis. And then meta-analysis of the combined modality treatment has very clearly said that the sequential chemoradiation versus RT is much better. And then concurrent CRT was also better than the RT alone. And concurrent CRT versus sequential is somewhat better. I think both are equally good. And as Dr. Vincent has said, in patients, it's not possible to give the concurrent CT-RT. We could go for the sequential. So these are all the results that, meta-analysis of concurrent CT-RT, without going into details. And so there is no place for concurrent CT-RT and a consolidation CT. I think Dr. Mark has shown very clearly that giving docetaxel, giving radiation, high dose radiation, many things, they're not worth it. So either you go for concurrent CT-RT, the first and the best one, or induction chemotherapy followed by the concurrent CT-RT. So the combination that we use are the cisplatin etoposide, cisplatin vinblastine, pemetrexed, carboplatin, PEMSIS, and carbopacli. So, and then of course, this also we've seen that when we give sequential versus concurrent, the difference is hardly anything. And so now I just asked the questions to panelists, starting from Dr. Nitesh. What would be your, we are not talking about the operable cancers, and when the operable are there, we'll come to Shubham and other people a little later. So Nitesh, what would be your thing? Do you always practice a concurrent CT-RT, or do you have any patients who are going for sequentials?
So almost always we do concurrent. So where we really feel that the patient performance status is very poor, then the patient is more or less palliative by performance status. So there we would use radiation, but that's not sequential. We use radiation with a wait and watch strategy or a targeted therapy or something. But generally, if the patient is stage 3 and we think that it is chemo radiation, then we would be planning for concurrent.
Right. And I'm sure in your multidisciplinary meeting, the surgeons are an important part of the discussion, right?
Always, sir. Always. And it's not a nice meeting. I can tell you that. Shubham been a part of it, but that's what it is.
So the thoracic surgeons would always feel that this is inoperable now or even later. So all those patients will be going for CT-RT. So Shubham and Darlong, both of them. Yeah, Ullas has joined. Welcome, Ullas. So Shubham and Darlong. So now what is your experience? And now we are harping on don't operate, stage 3, go for mostly chemotherapy, radiation, and so on. What will be your say on this kind of a patient?
I think, the surgeon definitely has to be there in the beginning, and it is a joint decision. Right. We all have talked about the heterogeneity of N2 disease. And so we need to discuss with the patients basically, regarding the fitness for surgery. So surgery should definitely be offered in those indicated cases, and it should be a multidisciplinary. That's the present approach that we follow for stage 3 disease.
So in borderline operable, I'm sure you must be seeing something like not initially operable, but borderline operable. Give him 1 or 2 cycles of induction chemotherapy, and in case he is operable, go for the surgery. In case not, go for CCRT. Do you have that kind of patients?
Yes, sometimes we definitely would not like to go for an immunectomy. In any of these cases upfront at the present scenario. So those will be the cases when we feel that if we go in now, we might land up with an immunectomy. So those are the select few cases. Yeah. And we intend to do a pulmonary, CT pulmonary angiography to really find out such cases preoperatively.
Dr. Manish Singhal, any difference of opinion, or you accept all this as a standard of care? He's there, right? I think I saw him, Manish Singhal. Yes, he's there.
Hello.
Manish, you're the...
Yes, sir. Yes, sir.
Yeah. So do you have any patients who will be not candidates for CCRT upfront, but do you ever try the induction chemo or some kind of a sequential chemo?
Yes, sir. So definitely there are patients who are not candidates for CTRT upfront. This can be because of performance status. Sometimes the tumor is very bulky. Right. And the radiation oncologists feel that it cannot come into a portal or the radiation. There's very high chance of radiation pneumonitis. In that case, we do induction chemotherapy. So I would say that about 20% to 25% would be candidates for neoadjuvant chemotherapy, and rest all will go for CTRT.
Right. So I think you made very valid points. Dr. Mark, we discussed extensively about the stage 3. Would you accept these two indications for initiating with the chemotherapy, not with the induction intent, but as a sequential? Patients who are not fit, or the portal of radiation is too huge to be given the radiation and chemo together. Dr. Vincent has joined us, or has he signed off? Is he there? Somebody can spot him? Okay, doesn't matter. Ullas, you can take on that question.
Question, sir.
That's a very nice question.
So I mean, you asked him to comment about this. A fair enough. I think it's a fair enough point. But my take on this is, sir, the decision for the management should ideally be made at the starting.
Right.
You can't say, when in doubt, give 3 cycles of chemotherapy and then, we will see after 3 cycles. I mean, that's not the right thing to do.
Okay.
I mean, the surgeons would, by and large, in their heart, both Shubham and Darlong will know whether this guy will be operable upfront or later or not. So sometimes we give neoadjuvant chemotherapy. They say, okay, the pulmonary status is not okay. Let's do a good prehabilitation. Let's give chemotherapy and then see, or maybe for the N2 lymph nodes, about how the N2 lymph nodes are doing. But by and large, sir, I think, the concept of that locally advanced breast cancer getting locally inoperable breast cancer becoming a locally operable breast cancer, I think it's very far and few in between. The surgeon has to take the call upfront, and every effort should be made, sir, because honestly, and my thoughts, sir, we have dealt with the common patients. Neoadjuvant chemotherapy, I mean, it has not really made any survival difference. So the point is, if somebody is going, so when in doubt, yes, we can go ahead, but it's not good to be always in doubt and say, 3 cycle chemo de do, and then we will see what to do.
Okay.
So I think the decision has to be made upfront in the joint committee. That's what I would say.
In short, you are saying either they're inoperable, ever inoperable, or operable patients, and there's
so
nothing.
The point is, sir, I mean, let's keep how many people, I mean, I think Shubham or Darlong can take, how many people are borderline convertible, which have been converted to by chemotherapy to that? I mean, in their experience. Shubham, can you take that?
So and have had an advantage and have advantage. I'm not only seeing conversion and haven't come back.
So when we talk of stage 3, I think we are just talking about neoadjuvant in relation to the T staging and not the end stage, because the end stage will not change our management. If it's going to be N2, multi-station N2, we will raise our hands up and we'll say that anyways, it's not going to, even if the primary is small enough to be operated. Now, the only indication where I feel that neoadjuvant can help is by giving us some time, like Dr. Ullas said, to work up the patient up better, build up the pulmonary function, and we know that this patient is anyways going to get chemo later on. How? But I just have good hopes with some magic immunotherapy or osimertinib coming up in the Neo ADORA trial and giving us some hope that we can make inoperable patients operable and give us more work.
So on this, can I just comment, Shubham? I mean, this time a single agent atezolizumab trial was presented at WCLC. And they said a major pathological response of around 22% and operability rate of around 81 to 82%. And mind it, it was a single agent immunotherapy. So I heard the discussion over there, and what they're saying is, if you have a stage 1, stage 2 disease where you want to prepare the patient, for for surgery, maybe go for immunotherapy alone. If you have a stage 3A patient, probably a chemo immunotherapy will be better. If our major pathological response are not PCR, MPR rates are much more higher with immunotherapy, probably that is the way to go forward. So I'm looking forward. The only neoadjuvant chemotherapy in lung is not CA breast, but neoadjuvant chemoimmuno, we might have a neosphere or a Cleopatra or a neosphere or something at our hand. That's what my take on this.
Right. Neo L2.
Right. So we'll wait for that particular thing. I think that's a good thing. So I'll come to the case discussion. Now, this is a patient. Patient is about nearly 60 years old. He presented to us in December 2019, and then he had the fever, cough, and weight loss. He was a patient of coronary artery disease post CABG. His CT scan chest, X-ray chest first, and that revealed a left upper lobe lesion. And then he had a CT scan and CT guide biopsy. The first biopsy, which was done outside, and then without IHC, it showed as small cell carcinoma of the lung. And then patient was not reluctant, not keen for this rebiopsy, and we did not have the IHC, and the blocks were not available at that particular moment. So then MRI brain, we did it, and then PET scan was showing, I'll just show you the picture. It's showing a lobulated mass in the left upper lobe, and this is a real case, showing the focal loss of fat planes in the descending aorta and the transfixial extension in the superior segment. Faintly, some small lymph nodes were also noted. So that's a picture. That's a picture. And then, so then we, now, how would you, Shubham, may I ask you? So if this patient had come, so how do you manage this patient? It's a small cell, obviously. I mean, we'll go for, it's a limited stage, we'll go for the chemo radiation, right?
Yes.
Right,
So
chemo radiation.
I had given up at small cell only. So
right, okay, fine.
So Shubham, even in small cell, Darlong does surgery once or twice a year.
Yeah, we have very, very selected cases coming to us,
Right.
luckily.
So, so maybe I'll involve Shubham a little later once the case develops. I mean, obviously, we're not discussing a small cell here. So this small cell, because we took it and I told you that we didn't have the IHC, and based on outside report, we started because that time it was very difficult to get the blocks and slides. So 2 cycles of etosis were given because we thought it's a limited stage and we'll go for the radiation, and the X-ray follow-up, the first and the second cycle did not show any change. So that's why all our antenna were up there. And then when we did a PET scan, because this is not the usual way that we handle a patient, but in this patient, because the X-ray did not show anything, so any change. So that's why we got the PET scan done. And it actually shows a very mild decrease. And then the central necrosis was seen, sub-centimeter nodes were no change. So that's a PET scan. That's a PET scan. You hardly can see any change. So we got suspicious. Are we dealing with small cell or are we dealing something different? So we asked for a rebiopsy, and the patient was very reluctant. After a long time, he said yes for it. And then meanwhile, the son went and got the old blocks. So we did the, we had a multidisciplinary meeting, everyone. And then this is just to show, the slide to show what Dr. Vincent was saying. Multidisciplinary team discussion results in better overall survival. That is something which I learned very hard way, that it makes the patient survive much better. I think it's more than true now. So in both the overall survival and all. So coming back to our patient, so when the patient did not have any change in the thing, then we got a IHC panel on the original biopsy, which showed adenocarcinoma. Here it is all listed. And then we did our biopsy. Our biopsy was done it was inconclusive because probably a radiologist couldn't reach the thing. So based on this adenocarcinoma, TTF though was negative, our patient has been given. So we switched him. So I'll ask now Ullas or maybe Nitesh, who else is there? Manish Kumar is there. Manish Kumar is there?
Yes, sir.
Yeah, Manish. So tell me, what would you do? So 2 patients, 2 cycles of Isisito given, and the patient didn't show any response. We did the biopsy. From small cell, it is turned into the adeno.
The patient has not responded to a regime, which should probably work in adenocarcinoma also. But since it looks like a limited stage disease, and presuming that poorly chemo-responsive, I'd like to take surgeon's opinion regarding the activity of this case and maybe adjuvant chemo later on.
So then
we change of regime.
We did refer to Dr. Darlong.
I think, sir, the image is not really complete for a surgeon to really decide about resectability.
Right.
We'll need a better CT pulmo angio to basically see what's the relation with your aortic arch and all that area.
Right.
So
right.
I will not be able to comment on this picture.
Okay, fine. So patient was in any case very reluctant to be considered for surgery, which is dawai se theek karo, that was the thing. Yes, Dr. Dal, we did discuss with our surgeons. He also wanted to have more investigation. But the patient was reluctant, so we did just left it, and then we continued with our treatment. So based on this, Dr. Manish, what would you do? The surgery is not possible because the patient has said no.
I would prefer to change the regime, maybe see from metoposis, maybe I would add pemetrexate based regime along with cisplatin and C. And yeah, probably that's what should be.
So PEM says, or I mean, would paclitacarbo do or not?
Sir, doesn't make a difference whether you add PEM-CIS or paclitacarbo. Hardly, maybe PEM-CIS a little better in EDNO compared to paclitacarbo. But
Thank you for that comment. So we went for the we actually offered. Yeah. So do we consider? Yes. Yeah.
So I would probably want to do an MRI brain first.
Yeah, we
to
have
find out
MRI brain that time. In the beginning, we have done that was negative.
Okay, so the second thing is, sir, I mean, everything is negative. On what basis have they called it adenocarcinoma? That's the second thing. It's a morphological diagnosis, I guess.
Yeah, possibly it's morphological, sir. They could be seeing glands, and that's how they are saying most.
Maybe.
That's why.
And the third thing is, I would probably want to consider a radiation. I will now like to involve the radiation oncologist and probably give RTCT because it's still a limited stage disease. Just because it has not responded to chemotherapy doesn't mean that we go ahead. So I mean, I would probably take a RT opinion now and then see if we can give RTCT to this.
Patient received RT, I believe, along with cisplatin.
Only 2 cycles etosis.
Would you not want a mediastinal?
Exactly. I think Ullas, I'm with you there. So he received 2 cycles of cis.
Even I agree with that. CTRT.
CTRT. So that's exactly what we did.
Would we not want a mediastinal evaluation even for the radiation oncologist to decide the radiation?
That's a $1 million question, Shubham, which is always said yes over here.
Yes.
And they go in and no radiation asked for that before.
Yes, that is why I'm bringing it up. Why was no mediastinal staging was asked for, or did the radiation oncologist feel that it will not change our treatment management? Although I agree that the treatment would be CTRT only, but then I
would totally agree with you. I mean, my point always is for a surgeon, when you can say India is a tubercular endemic disease, pandemic and the lot of lymph nodes can be tubercular. I mean, for the radiation oncologist also, we should actually probably try to evaluate the mediastinum. I would agree with that.
Right. So yeah, we didn't honestly think of it, but maybe next patient we would. So we went for the CTRT rather than any more chemotherapy. And then the only difference is that we chose the pacli and carbo weekly, small doses. I think there was a discussion about the chemo regimens, different chemo regimens, all the same. I don't think we'll go into that discussion, but we did that. And then he received the standard RT. And then at the end of the radiation, about 6 weeks later, we assessed him and the whole lesion actually disappeared. This is the PET CT. Are we all happy with this kind of a thing now?
I would probably reassess now with durvalumab being available, sir. I would reassess him at 2 weeks the CT scan. Right. If there is no RT pneumonitis and everything, and if we have done a EGFR ALK on the block which is negative, I would want to offer him a durvalumab based maintenance immunotherapy, consolidation immunotherapy. Right. But I would like to do an EGFR ALK prior to that, and reassess at 2 weeks.
Fine. So we did send it for EGFR. Unfortunately, the tissue was not adequate. But then, so I think this is just a theoretical discussion. Before the Pacific study came, multiple things have been tried, and then nothing really worked. So I think I'll skip all this. So would you consider? I think answer is already yes. So, but I don't want to go into the complete trial. We all know that Pacific study, what all it showed, and we had an extensive discussion by 2 speakers. So coming back to this patient, so he did have response to the chemo RT, and then we put him on the durvalumab straight away because we knew Ullas is going to say the same thing. So for Ullas' sake, we did that beforehand. So so he got it, and then we had the thing, right up to March this year he's been getting, and this is the recent PET scan which was in December. It's further reducing. Patient was doing very well. He did not actually have any symptoms of radiation pneumonitis so far. So I think we continue to get it, and we're going to a 3-monthly scan. What is your schedule of follow-up in such a patient? Anyone can see. Nitesh. So a patient who's on durvalumab maintenance, how frequently do you do the PET scans or CT scans or X-rays? What is the most optimal, cost-effective investigations?
Durvalumab, you don't talk about cost-effective, sir. So there are 2 things that I don't want to do a PET CT scan. So what I normally do is I would do a CT scan after 2 weeks. I would definitely repeat a PET CT scan at the end of 3 months from radiation. And then what I have learned in immunotherapy is, sir, probably avoid a lot of PET CT scans because in RGCI, again, we have an issue of PET CT without CT chest actually. I would probably do once in 4 month CT scan chest and upper abdomen for this patient, including an MRI brain.
Right.
One very important thing I would want to do is, sir, endocrine workup. I think we had
Right.
given 5 or 6 patients durvalumab while it was being given free. A lot of them have developed hypothyroidism. I would want to do that very regularly, once in 3 months, actually.
Yeah, well
That's
said.
all.
Okay. Hypothyroidism is, of course, within. So this is the question. So first time of assessment, I think, Ullas, you already answered. So the CCRT is over 2 weeks, hence you should do a CT scan or a PET scan, right? Or what are you say?
Yes, sir.
Because most of the radiation oncologists would do in between a CT scan of the chest with their own report. Is that adequate, or should we do a PET CT?
No PET CT scan, sir.
Yeah.
CT scan in 2 weeks time.
2 weeks time. Okay. And then the best time to start the durvalumab is the next thing.
Yesterday. After two, I mean, sir, the best time was at 2 weeks, but that also basically says, sir, that people who are more fit. So probably, you know, I mean, they said that so the trial also included later on till 6 weeks, till around 8 weeks also later on. But they felt that people who probably did not develop much of radiation pneumonitis were the people who were randomized initially. So I would say 2 weeks ideally, but I would be happy to give it with 2 weeks to 8 weeks also.
Okay. And then is it chemo dependent? I mean, the patients are getting different kinds of regimes, cis-ito, ito-carbo, and then, pacli-carbo, anything. So
No,
is it dependent on the thing, anything? Manish has been quiet. He could just answer. Is it?
I have been speaking more. He's not been quiet. I'll keep quiet now, sir.
So what is the question, sir?
Good. So the question is, when do we start the durvalumab? The duration, the time.
So, sir, as early as possible, but usually within 42 days.
Within 42 days. So is the delay or earliness, would it be depending upon the regime that you have used for the chemotherapy during the CCRT?
Not really. It doesn't really depend on the regime. Although there is some data to suggest that with paclitaxel there will be increase in the risk of pneumonitis.
Right.
But we have not really encountered that problem. Not that we have used a lot of durvalumab, but I don't think so. Still, paclitaxel carboplatin remains one of the the protocol of choice for chemotherapy. But we generally tend to start within 4 weeks or so. Although there is some data to suggest that if you start within 14 days, there was an ISMO presentation that it is even better. But I think that was a post hoc analysis, and we can't really depend on that particular analysis.
So is there any difference when you start early or late in the incidence and the severity of the radiation pneumonitis?
I don't really think so. Also to add that there is some data to suggest that even if because of any reason there is a delay beyond 42 days, one can still derive the same benefit from the drug.
So on one hand, we have information real-time data that you can start it after 42 days, and you have the data that you can start it early. The results are almost the same.
Almost the same.
Yeah.
Although there is data to suggest that within 14 days, if you start, there may be some survival benefit, but that was a post hoc analysis of the same trial, the Pacific. And I don't think so that one has to take it with a pinch of salt that whether the patient is ready to receive it so early or not.
Right. And Ullas, in your center, I mean, you're starting at 2 weeks, 3 weeks, or?
If the patient is doing fine, I try to start within 2 to 3 weeks. If the patient is doing fine, if there's no pneumonitis, but I won't. So I mean, I would answer it in this way. I would like to start it within 2 weeks, but I won't delay. I won't mind if the patient has not received for 6 weeks. Also, I would want to get durvalumab.
And then radiation oncologists are okay to allow you to do that.
उनके पास पेशेंट आते ही नहीं सर हमारे पास आ जाते हैं.
So we have Dr. Puneet as radiation oncologist. Sir.
Yeah, Dr. Puneet. Yeah, please come on, Dr. Puneet, your comments. So you just heard Ullas, saying you don't call your patient.
Radiation के बाद नहीं आते हैं.
Pardon?
Radiation के बाद थोड़ा जाएंगे उनके पास सर.
क्यों नहीं जाएंगे भाई? Puneet, don't they come back to you? Is he there, Dr. Puneet?
I hope not. I really hope not.
Okay, fine. So I think we discussed about the EGFR. So now should we start doing with the data that is coming up in these patients about the EGFR? First is it's not effective. Durvalumab is not as effective in the EGFR negative patients. So, and then we also have the data that adjuvant or the neoadjuvant osimertinib is going to help them. Should we do an EGFR estimation in all stage 3 patients?
Yes, sir.
Every patient.
And sir, in fact, I think not only that, even in the neoadjuvant AGAN study that I think both of us are having in our center, in that also they are saying that if you're having immunotherapy, please look at the EGFR, right? Because typically immunotherapy won't work in a oncogene-driven lung cancer.
Right. So the rest of the questions I think we have already discussed and have been answered. Next one. Right. So what is the future in the stage 3 patients? Anyone can take on these questions. What is going to be? So there are some studies of dual monoclonals. There are something like the whole thing, like there's one keynote 04, if I remember correctly, there's where they have given only the Pembro in the patients of the stage 3 without any radiation and all. So there are many things which are happening in this area of stage 3. Any comments from anyone? Manish, Ullas?
So
Manish,
Manisha, please go on.
Nothing, as it has been discussed, like all sort of neoadjuvant immunotherapy combination with Nivo-IP, or even neoadjuvant TKI, like one of the studies which showed erlotinib is better than Gemcis. So those kind of things, they are underway. So maybe going ahead, we'll have some answer to that. But it'll be interesting. Neoadjuvant immunotherapy definitely making more sense.
Right. So in the post CCRT setting, is there anything new coming up, Manish Singhal or Ullas?
Sir, I think as IO plus CTLA, the checkpoint inhibitors, PDL1 plus CTLA combination, durvalumab and tremelimab is coming up.
Right.
I think that is one. Then also again, sir, whether we can measure. So does every person need it? We can do a ctDNA measurement. Then you can decrease the duration to 6 months versus 12 months. So all these new trials, I think Pacific 7 we are participating. Also concurrent with RT, you have Pembro plus chemo plus RT. Neoadjuvant immuno is also coming up. So all these new things are coming up.
New things are coming
but I think it has been a fantastic because something which did not change for last 40 years with Pacific trial has changed. So that's a fantastic
right.
thing to be.
So tell me, you're mentioning something new. So based on that, I'm asking a question. So liquid biopsy, or do you do any ctDNA measurement in such patients to know the prognosis and to monitor them?
So we are now doing not in stage 3, sir, because numbers, when you write a project, you should have numbers. Right now, we don't have that much numbers for CTRT with us because Dalong operates everyone. For a stage 4 lung cancer, we are doing a research, sir, in which we are measuring ctDNA before the study at day 15 at 2 months level with CT assessment, and we are saying whether an early response to that, the nadir, will it help us in telling whether the patient will respond better or not. Also, we are also saying, because a lot of time after 4 cycles they have an IUPD. So let's say most of the reports are IUPD. So let's say if you have an IUPD and your ctDNA level is actually going down, probably continue. If it's going up, probably don't continue. So that I think we already have got 19 patients on that. I am planning to submit it into this ISCLC. Fingers crossed. I'll keep you updated with the results.
Sir, I have a question with Dr. Ullas.
Yeah, Manish. Yes.
Yeah, is that your background or they are real books?
We are doing a research. Oh, okay, this one. Okay. I would like to believe this is a real book.
Background.
It is a background.
He's trying to impress. He studies a lot where he does.
It's all Google.
Okay, sir.
Dr. Rangaram knows me very well.
Thank you very much for a wonderful discussion. And then I think any questions from the audience who are there now? Dr. Sham, any comments? We saw you when so quiet. I'm sure you.
Sham sir, I am going.
So anyone else? Dr. Bharat?
No.
Okay, fine. Okay. So I think then we will leave it to the organizations. Over to you, Samit.
Thank you, Rangarao, sir.
Yeah.
I think it was quite informative, adding to the difficulties in managing stage 3 lung cancer. There are no easy answers and one solution to all. So I think more we keep having these discussions, I think we'll become more clearer on individual cases, how to go about it, N1 disease, N2 disease, EGFR, ALK, immuno, how to integrate them. Thank you for a good insight, sir. And thank you for teaching us once again as a good teacher you've always been to us.
Yeah,
thank you, sir, very much.
Second that.
Yeah.
And thank you to all your panelists also, Dr. Ullas and Dr. Manish, all of you. Very informative, experiences you gave us. Thank you all. Okay, with this, we now go on to our next speaker. Is Dr. Bharat Vaswani. Dr. Bharat Vaswani is a medical oncologist from Yashoda Hospital at Sikandrabad. He's a graduate from the famous Onco Center of Gujarat Cancer Research Institution. and he would be telling us something about osimertinib, which seems to have taken over the EGFR positive lung cancers in a big way. And let's see his insight into the role of osimertinib as a third generation TKI, and does he think there'll be a fourth generation and a fifth generation TKI osimertinib also? So kindly I'll request Dr. Bharat to begin the speech.
Good evening, respected seniors, my dear colleagues. Thanks to the organizer for the kind invite. Importantly, are my slides visible and am I audible, sir?
Dr. Bharat, yes, you're audible, please.
Yeah, thank you. So the topic that I'm discussing, actually it has been discussed a lot of times, but some things I wanted to tell and something. It is not only osimertinib. I'll try to give you a brief overview of the entire treatment option, and at the end why osimertinib still should be the best first-line treatment irrespective of all your mutation status, which we keep on discussing. So all of us will agree that in the last 20 years, the most wonderful thing that has happened in the management of non-small cell lung cancer is the discovery of this typical, or which we say the wonderful molecular aberration in the tyrosine kinase domain of transmembrane EGFR receptor and the class of the drugs which are targeting this specific mutation. In fact, discovery of this mutation and the treatment has led to paradigm shift in the management of non-small cell lung cancer. From a seamless disease where the survival 2 years was a big thing, now we have a survival which is close to 3 to 4 years, and probably this is not the end, and we'll be having the survival may keep on increasing with the discovery of new and new drugs and with the proper sequencing. It started in the first line with Tony Monk study, IPASS, where gefitinib came, and in the subsequent 12 years now, we have 8 different combinations which we can try as a first-line treatment in this mutant EGFR non-small cell cancer. So in the next 20 minutes, I'll be telling definitely on a Monday morning, if a patient have all the resources in the world and the patient comes to you with this mutation in a first line, what should be your treatment of choice? So if I have to divide, it is divided into either a single agent, which could be a first generation gefitinib or erlotinib, or a second generation afatinib, decomitinib, or of course the blockbuster osimertinib, which is a third generation EGFR TKI. In the last 3 to 4 years, we have seen 2 novel things. Combination of EGFR with either an anti-VEGF. Does it really have a role in the first line? And if it has a role, in which 2 subset of patients, I will be telling you, you may think of giving it. And definitely EGFR plus chemotherapy, where the trial from Tata by Norona madam has really changed the way we look into it, because being a first Indian trial and showing such an impressive PFS and or OS, should you consider this as a first-line treatment in your patient? Now, when you look into the NCCN guidelines, fortunately, you say osimertinib definitely we know has been kept apart from others in the upper part and other TKIs in the downward part. Now, when you think of giving your TKIs with anti-VEGF, it is not a category 1 recommendation, probably because there is no OS data to suggest that it really works. There is a PFS1 improvement, but no data to suggest that there is OS improvement. And more surprisingly, there is nothing to suggest that chemo plus anti-EGFR TKI, that should be the first-line treatment. Reasons unknown, but possibly the reason could be that these are single country studies. And probably we may need more multi-centric trials to suggest that really this should be the standard of care, and probably no regulatory authority has still suggested it as a first-line treatment. On a Monday morning, if I have a patient with a mutant EGFR non-small cell lung cancer, what are the factors which should tell us to decide which should be the best treatment option? So it should be divided basically into 7 parts, and I'll be telling you one by one, and probably in the end, what should be the thing. The most important, and one of the most important thing is, how is the drug responding and how much percentage of the patient have a response? So a systemic response rate, and now with these, we know 25% of the patient with EGFR TKI may develop a CNS met. So what is the CNS efficacy? The most important thing, if the drug works, how long it may prevent the disease from progressing, and the most important of all, whether addition of this drug may improve your overall survival or not. All good things have bad things. So of all the things, which is the drug which is the safest, probably now being this drug to be given for a long period of time, because if you look into the data, 16 to 20 months PFS is the thing that we are now trying to get it. So will the patient be able to take this long duration of treatment on a single drug without a treatment interruption? That is something that we need to see, that I'll be emphasizing in a chemotherapy plus TKI arm. Probably the oral should be preferred. And a country like India, definitely the scenario is not every one of us can afford the treatment of choice that we discuss in all our clinical meetings. So this was the thing. You have to tick your 7 boxes for us to say that, yes, on Monday, I'll be using this drug and I'll be discussing for it. Now, let me start with the single generation TKI. Now, when you look into your registration studies, Gefitinib IPAS study, Erlotinib Yortec study, Afatinib 2 studies, Decomatinib Archer 1050 and Flora study, of course. Now, when you look into your response rate, probably the response rate have improved from 60% to 70% in a first line TKI to 75 to 80% with either a Decomatinib or a Osimertinib. And when you look into the PFS, this is most important because this gives you the main effect of the drug. 9 to 11 months with first generation TKI has come up to 14 to 15 months with the second generation, and definitely around 18 to 19 months. This is what we are trying to achieve with a new, that is third generation Osimertinib. And when we talk about the most important point, around 21 to 24 months in the first generation, around 30 to 34 months in the second generation, and around 38 months in the third generation. So if you see, if you do a head-on comparison, definitely we should not encourage. All of us know and has been proven repeatedly that the drug which gives you consistent better ORR, median PFS and OS is Osimertinib. So no confusion, which is the best drug around. There may be some debate that you may use exon 21 Decomatinib, but Decomatinib is a very toxic drug. Everybody will agree. All are, again, you say exploratory endpoints and you keep on discussing with it. What about first or second generation TKI? So 2 landmark study, Lux Lung 7 study and Archer study. Archer study has shown impressive results, but one most important thing are, these are super selective patients, more importantly, without a CNS disease at all. If you look into your Lux 7 data, 16% had stable lung mets, and when you look into your Flora data, it was 19% of the patient had stable CNS mets. So Archer was a very super selective, highly fit patient without any evidence of CNS mets which were taken in the study. Now, I will like you to look into the hazard ratio. 0.7, this hazard ratio is 0.73. When you give Afatinib, there was only 0.1 months improvement in PFS, but this was statistically significant. And when you look into Decomatinib data, absolute gain of around 5.5 months with a reduction in the risk of progression by 41%. So if you see now in your Flora also, it will this hazard ratio is less than 0.50. So 0.7, it came down to 0.59 with second generation. And now with the third generation, it has further come down to less than 0.50. So definitely when you even look into the hazard ratio, there is a decrease, or the quantum of benefit is better when you are giving your third generation TKI. And the most important thing when you say second generation, yes, there was a statistically significant improvement in Archer, the first study which showed OS improvement as against Lux 7, which did not show any OS improvement. So the study which showed before this was an Archer study, but definitely a super selective study. The only thing when we discuss about Archer is there are impressive results, but 65% grade 3 side effect, around 10 to 15% disease discontinuation, 65% dose reduction, and a super selective patient. Even in these patients, there was a lot of disease reduction, as good as 6 in every 10 patients. Then came the blockbuster study, Flora study. Only few silent points were stable CNS mets, which were 19% of the patients were taken, randomized to Osimertinib versus first generation TKI. More importantly, before this study, they were non-crossover, but this was the first time this was a crossover study. So around 31% of the patients in the second line were able to take Osimertinib when they had taken a first generation TKI. The primary endpoint was a PFS. This is most important. And the secondary endpoint was the OS. Now, when you look into the forest plot, there was a statistically significant improvement in the risk of progression. So it was 0.46. Remember your 0.59, it came down to 0.46. So a 54% reduction in the risk of progression with the absolute gain of around 8.7 months. And when you look into your forest plot, there is always a debate when you come into OS. But if you look into your subset analysis of CNS mets, more importantly, L858R, there was a statistically significant improvement in your L858R. You can see your chemo plus EGFR data also. These are not as good as what is in there in terms of PFS, which was the primary endpoint. OS was the secondary endpoint. So what was given post, and in how many patients this osimertinib in exon 19 or L858R was given osimertinib, we don't know. Now, when you look into this graph, what it is suggested is the benefit starts early with osimertinib, as against the other two drugs where it may take time for you to see a difference when compared to first generation gefitinib. So for FLORA, one more added point is a faster response and an immediate response, which are better than the first generation TKI. More important thing, there was a lot of debate that we could not get that quantum of benefit in OS that what we got in PFS. But the most important thing is 31% of patients were able to take this drug in the second line when they were T790M positive. Still, at the end of the day, there was a statistically significant improvement in OS, and the hazard ratio was quite impressive, 0.79, meaning a 21% reduction in the risk of death. If you look into the benefit also, around 7.5 months improvement in your OS when you give osimertinib, definitely 30% were able to take it in the second line, and that has more or less diluted the overall survival result. Added advantage, actually, I think so, the only study in the phase 3 setting which has shown that giving this drug in a CNMET, in fact, I think this should be the only drug which you should prefer rather than debating about other when there is a de novo CNS MET, because there was a statistically significant improvement in PFS with an impressive hazard ratio of 0.47, that a 53% reduction in the risk of progression in patient with a CNS MET. So probably the only study apart from the other advantage that I told you. Now, a grade 3 toxicity. Now, I'll be telling you in the later part, 18% is probably the least, in fact, lesser than even with the first generation TKI, the grade 3 toxicity. Think of your afatinib more than 50%, decomitinib 63% grade 3 toxicity, chemotherapy with TKI 65 to 75% grade 3 toxicity, EGFR TKIs with VEGF, again your 70 to 75% grade 3 toxicity. So less than 1/3 of the grade 3 toxicity this combination has, with the commonest being diarrhea, paronychia, some upper respiratory tract infection, and some liver abnormality. But probably when you do a cross trial comparison, the drug with the least grade 3 toxicity is osimertinib. Always keep on debating between whether you should use the osimertinib in the first line or you should combine your chemotherapy with the first generation TKI. Now, there were two studies. Again, these were single country studies, the Japanese studies and the Tata study. My only apprehension with this study is the maintenance arm. So basically, the maintenance arm of both these studies had chemotherapy as a maintenance arm, not a TKI. When you look into NEJ study, which compared gefitinib, pemetrexed versus gefitinib, the maintenance contained Jef with Pem. And when you look into the Tata study also, the maintenance arm was pemetrexed. Now, when you look into the progression-free survival, I'll put it, at present, 50% or more than 50% of the patients will be having a progression-free survival of 16 to 20 months. Think any of your patients in the last 1 year, how many of your patients were able to continue chemotherapy for 16 to 20 months? I'm not telling people may not tolerate it, but in a COVID era, a patient coming to you for 16 to 20 months for taking a maintenance chemo is a technically impossible job. In my end, if I think of it, 10 to 20% of my patient can, even with the best of response, comes for 16 to 20 months to take the maintenance chemo. So the few drawbacks that I have drawn are what I think so is the maintenance arm, if it would have been a single agent TKI, probably then it would have been a 4 cycle of chemo and maintaining. These are chemo which are continued for 16 to 20 months and then you are getting the benefit, as against the oral tablet for osimertinib. Maybe a very high grade of toxicity, grade 3, 65 to 75%, an appreciable number of drug discontinuation rate, and more importantly, a single country study, although appreciable, and unfortunately still none of our standard guidelines have taken this as a standard guideline. But definitely I use it in my patients if they can't afford osimertinib, and this is quite a good combination gives you. But definitely 16 to 20 months of IV chemo difficult in this COVID time, I believe. The third combination that has evoked quite a good interest was a combination of your TKIs with a anti-VEGF, either a bevacizumab in NEJ-026, which is a Japanese again, and a relay study. Again, you need the relay or a super selective study, and hence the responses or the PFS are slightly better in NEJ-026 study. You need to give either a long-term chemotherapy also in these studies. Now, again, NEJ-026 had a very impressive PFS1, so nearly twice the improvement with the risk of progression of 0.60. But when you look into the updated analysis that was published in ESCO, no improvement in PFS2, no improvement in OS. So probably it would have just delayed the event. It has not reduced the event at all. So a trial which has shown your PFS1 improvement with statistically no improvement in PFS2 and OS. I'll be telling you two indications where I think this combination still holds true. Again, the second study, relay study with ramucirumab with erlotinib, you have a very impressive improvement in PFS1, again a 0.59 hazard ratio, so more or less 40% improvement. But again, we don't have an overall PFS2 data or an OS data also. So this thing, something I think so, probably that is why it has been given a 2A and a 2B. 2A has been given to ramucirumab combination and 2B to the bevacizumab because it has not shown any improvement in overall survival. So a more important thing is a grade 3 toxicity. If you see your grade 3 toxicity, 88% in the Bev arm, 72% in the ramucirumab arm. So 7 of the 10 and 9 of the 10 will have some degree of grade 3 toxicity in this. A higher rate of discontinuation, nearly 29% in the Bev study and around 10% in the ramucirumab study. 10 to 13%. So that is what this combination is supposed to be, a toxic combination with probably some improvement in PFS, but no long-term data available. So probably not an ideal combination in the first line till you have a more clearer data about its definite benefit. And if I have to say in a nutshell about the three major studies, your chemo plus your anti-VEGF with EGFR, your chemo with this, when you look into your response rate, anywhere from 70 to 80% patient will respond in the three combination. When you look into PFS, 16 to 20 months in all the combination, no studies except for Flora study has shown that there is definitely the benefit of this combination in patient with de novo CNS mets. When you look into your OS, again, there is no data OS improvement in VEGF with TKI combination. So improvement is definitely there with chemo combination, but yes, it is associated with a fairly big toxicity, a longer duration of chemotherapy. 16 to 20 month patient have to come to hospital to derive such quantum of benefit. That is probably for me the most important drawback. Suppose if I don't use osimertinib in the first line, something that we have discussed repeatedly, that in practice, half of the patient will have a T790M mutation and around 1/3 of the patient may not take your second line subsequently, maybe because of progression, maybe they don't want to take it. So in practicality, 30% of our patients take osimertinib in the second line. Again, agreeing that if you are lucky enough to have a T790M mutation and if you are able to give your patient your osimertinib in the second line, maybe you may get the same benefit. But you are leaving this to chance rather than on the scientific basis. And that is what is the drawback for this study. As again, if you see in these pivotal study, IPASS, NEJ studies, 1/3 were not able to take any treatment in the second line. So why do you leave it to chance and trying to sequence it? You can still sequence it, but if you have the resources, try to give your best combination. What we'll be seeing in the future, I'll be telling you. Again, the goal, 31 and 30% of the patient were not able to take any of your second line treatment, and around 47% of the patient in the comparator EGFR TKI were able to take osimertinib. All in all, around 31%, and that is what we see. Out of 100, 30 to 40% of your patient can only take osimertinib in the second line. A nutshell about all the 7 points that I have told and the 8 combination. 3-star is what we say, your child gets a 3-star, so he's a hero. So efficacy, 3-star, yes, with chemo and osimertinib. CNS, only one drug with a 3-star. Safety profile, only 2 combination have 3-star. Patient compliance, again, only 2 combination having 3 stars. PFS, again, a few drugs having 3 stars. OS, yes, only chemo with this a 3-star, and cost only side effect. So if you compare your data of all the drug which gives you all consistent benefit in all the out of the 7-6 parameters is osimertinib, and I think so no much debate about it. So this combination ticks all your endpoints. All debate starts with whether you should treat, even Ullas sir will be discussing it day after tomorrow. Should you treat your exon 19 and L85R mutation differently? What if you progresses on osimertinib, and what should be the best sequence which will give you the best OS advantage? Now, the controversy came because of FLORA forest plot. When you look into your exon 19, there was improvement. Exon 21, there was improvement in PFS. Unfortunately, if in OS, there was not benefit in L858R. But the thing is, how many of these patients in the second line in exon 19 or L858R could take osimertinib? We don't know. Probably that was something to be learned, and probably we should know how many of them had taken it in a subset analysis. So what should be the best drug if you have an exon 19? So probably the best data, not a cross-trial comparison or a subset, is if you have an exon 19 or what we say exon 21, the drug which has given you the best PFS as the combination of TKI with a bevacizumab. If in fact, if you see in the study of NEJ 026, it was L858R, the PFS was better than in exon 19. Secondly, this is something that I think we should start doing it, T53 co-mutation. If you look into your relay study, around 42.9% has T53 mutation, and probably we all know that either a EGFR TKI or the other, they may not do so well in this subset of patients. But if you look into it, the exon 21 PFS, and in those with a P53 co-mutation, there was impressive PFS with the combination of EGFR TKI with the anti-VEGF. So in my practice, if I have to think of giving this combination of EGFR TKI with the VEGF, it should be either maybe exon 21 or definitely in those with a P53 co-mutation. I think this is a hot topic that we should be having more discussions in the future. What about resistance to osimertinib? Actually, this is something that I think the recent data will tell it. One of my patients who had a MET amplification, but definitely after a crizotinib on capmatinib had a CR, complete response. So that is why probably we should start doing our mutation testing more, because now with the availability of capmatinib and savolitinib, probably this subset may do wonderfully well, but we will see in the future how it goes. So 4 mechanism of action most important for those who progresses on osimertinib: MET amplification, we are having a drug to counteract it; HER2/neu amplification; secondary EGFR mutation; and definitely PIK3 mutation. So future may tell us how you do your sequence will based on the studies that are coming up in the future. More importantly, you don't get your T790M mutation on osimertinib, and the mutation profile is quite different. But the important thing is we are now having drugs which can counteract these mutations, a subset of mutation, and probably it will be interesting to note what will be the overall survival in those when we sequence it with these drugs. Now, I think so the debate may end in future when we get the combination of the first line study in the lower third. We always discuss Arlo with Bev, Arlo with ramucirumab. What about osimertinib in these? So the future studies will tell us basically, even with chemo, we have a FLORA2 which will be assessing osimer with chemo versus osimer followed by osimertinib with a single agent plan. So probably this study will once for all settle a debate. But what I feel is osimertinib has to be there. You may combine with this. And the Orchard study, if you see, probably this is the way we will go in the future. You will do your mutation profile after you progress, and depending upon the mutation, you may add on your drugs like savolitinib, gefitinib, or netitumumab as per as your mutation profile. $1 million question, the last slide. What sequence will give you the most significant overall survival benefit? Now, if you look into all these sequences, the best treatment results are wherever you have used osimertinib, either in the first line or in the second line. So that is what the gist of my presentation is. You may not leave your this drug based on whether you will have your T790M mutation in the future or not. For getting the best result, either in a first line or a second line, if you are lucky enough, you should have this drug in your treatment, either in any of them. But definitely, This question will be answered better in the future when you have these pivotal, the remaining studies that I told, that will, once they get published, you may have probably the right combination. Regarding the fourth generation TKI, yes, there are two drugs that are being which may supervent your mutation status. But yes, you should wait for the results of those studies. As of now, osimertinib with or without or in a sequence probably should be the way to go, provided if the patient can afford it. So if I have to summarize, a drug which gives you a significant, probably 18 months of PFS, a drug which gives you a 38 months of OS, probably should be the drug, and the drug with the least toxicity, best CNS penetration, one of the best overall response rate should be the drug that you should prefer. Definitely, I think so. This survival of 38 months, probably with this new drugs that we are giving in those who progress on osimertinib, because I have a patient who has gone in CR also, so I am quite enthusiastic that if you keep on sequencing and with the due discovery of the drug or with the use of these drugs like capmatinib or with other mutations, probably you may have a better survival. So if I have to summarize, a drug which ticks all your good points like a PFS, response rate, CNS efficacy, PFS, OS, safety, compliance, probably should be the drug that you should start in your first line in all your patients with a mutant EGFR TKI in a non-small cell lung cancer. I thank you all for your patience.
Thank you, Dr. Bharat. I think it was very, very informative that you covered it. The topic is open for discussion. Any questions to Dr. Bharat, please? Dr. Bharat, if there are no questions, I have one or two questions for you.
Yes.
I would like to ask you, you already said so, that post osimertinib, you're going to look for MET gene. Anything else you recommend to us post osimertinib progression?
Probably the most common is MET amplification. Apart from this, what literature suggests is the second common is C797S, probably where gefitinib works well. You have PIK3 mutation, you have a HER2 amplification. I think so. These are four common. Then you have some of a RAS mutation, also a small subset with a squamous and a small cell transformation. The endpoint is we don't have a proper data about the drugs that we have used in a second line following osimertinib, and probably that may tell you that using these drugs following the progression, what is the OS, and that will probably solve this question of sequencing once for all.
And Dr. Bharat, you also told us that in case of exon 21 mutation or a P53 co-mutation, you would prefer the combination of ramucirumab with erlotinib. Is this now proven by trial or?
Sir, if you look into lung consensus guidelines, if you see, they have recommended strongly as decomatinib combination or icotinib, the other drug that we have not been using it. Now, if you see in a phase 3 setting, these are the combination which have really shown you the benefit in this subset more than what they have shown in exon 90. That was something of a surprise also. So probably when you think of giving if you don't think of giving your osimertinib in a first line, I think the best combination in both the studies consistently, even with BEV also and with ramucirumab, that has given you a better PFS improvement in exon 21 is this drug. Not in NCC and ESMO, but if you look into your lung consensus guidelines, they have strongly recommended this combination with decomatinib and icotinib.
I think that's really interesting, Dr. Bharat. Any more questions from the house, please, from the audiences? Dr. Bharat, there's one more study called the GEO-TAG study, in which they sequentially used afatinib followed by osimertinib.
Sir, that is all because, sir, listen, that study showed that if you have a T790M, you will get the response. That is what I am telling. As long as you are able to use osimertinib in first or second line, you will get that benefit. But again, you are leaving it to chance. This was basically a retrospective study which has tried to look into it, NeoTAG, but it was never a prospective study. I appreciate and agree that as long as you are able to use your osimertinib in the second line, you will get your improvement in OS. But again, 50% of the patient, although in exon 21 it will be 30 to 40%, which will have this T790M mutation positive. Suppose if this mutation is negative, you may not get this benefit. So Geotech basically was a study retrospectively in those who had sequenced it with afatinib followed by your startup. So again, based on T790 only. The thing is, you should use it whether in first or second line. First line, definitely if you can give it. Second line, only in that subset, 30 to 40% you may use it. So try to delay it to second line with the belief that T790M will be positive, and then only you can use it. That was my argument.
Last but not the least question is the cost factor of osimertinib. Most of patients will not be able to afford it. So would you recommend in such a case, let me complete the question. Would you recommend in such a case using of chemotherapy with first generation TKIs like gefitinib in patients who can't afford it? Would that be your choice, sir?
Sir, that is what in most of my patients, if they cannot afford osimertinib, I use EGFR TKIs with chemotherapy. The only apprehension that I have tried to find out to you is the maintenance arm, it has IV chemo, not as a TKI. So probably the problem with it, after 8, 9, 10 months, many of the patients may not take this chemo at all in the maintenance arm. I think that was the only drawback which I could think of it is. If the maintenance arm was a single agent TKI, I would have gladly accepted it. It is only 4 cycles you are giving gefitinib, and then you are continuing your PEM for 16 to 20 months. So in a COVID era, sir, calling your patient for 16 to 20 months, it's difficult. Nobody, unless he is nearby your place, he may not come every 21 days for 16 to 20 months, which is a maintenance arm in this chemotherapy plus TKI study. That was the only drawback that I could think of. But definitely I use it, sir. The thing is, you should never use your single agent TKIs now as a first line. Whenever you use it, you use osimertinib. If you can't afford your osimertinib, give your chemo with TKI as a first line. Because this is the combination which will give you 16 to 20 months of PFS when given in the first line.
Okay, Dr. Bharat, thank you very much for a very illuminating talk on EGFR osimertinibs and the complexities also involved in this specific kind of cancer. So there are no more questions. Thank you once again for a wonderful talk. Now, with this, we come to our last session of the day. And I would request our very senior medical oncologist, Dr. Shyam sir, who's many of us have been students and who has taught so many of us how to practice good oncology, to kindly conduct his panel discussion with his team on small cell lung cancer. So may I request Dr. Shyam to kindly take over and begin the discussion on management of extensive stage small cell lung cancer, a case-based discussion. Dr. Shyam, please.
Yeah. So thank you, Dr. H.P. Singh, and thanks to the organizers, Sushant and Samit. So I think we're running late, but we'll try and do it in 15 minutes, I guess. Are all the panelists there? I have the names. Can I name them, or Sushant or somebody can tell me who were there and who were not there?
Sir, Dr. Safalta is over here.
Yeah, I can see her.
Yeah.
Hello, sir.
Good evening. Yeah. Shefali is there?
No, sir. Shefali is not there. Dr. Varun Goyal is over here.
Okay. And Dr. Sahai or Devvrat?
Dr. Devvrat is also here, sir.
So let's begin. I think, can you share my slides? I think this is a sponsored session and the slides are, provided. Basically, it's a case-based discussion on extensive stage small cell lung cancer. So the idea is to figure out, what is the way to manage these patients who come to us. So small cell lung cancer, as we know, constitutes around less than 15% of all lung cancer. So it's not a very common, but it's not uncommon either. So Safalta, you see a lot of these cases before they, can you share the slides, please? Yeah, Safalta.
Yes, sir. So which is 15% already. So a lot of cases to nahi, but yes, I've been looking at extensive stage small cell lung cancer frequently.
So maybe 1 or 2 a month?
Yes.
Right. So I think you are a big center with the radiation on. So what about Dr. Varun Goyal? So Shant, you have the slides, the organizers.
So I'll just tell the IT team, sir.
Yeah, Devrat is there.
So no, sir, I am there. I'll answer it, sir.
Right, sure. Go ahead. I mean, at your center, how many cases do you see every month or whatever?
So I think about 5 to 6 patients we see of small cell lung cancer, and majority of them are in extensive stage. Rarely, one or two, maybe in 6 months we see limited stage, sir.
Right. So that's not a uncommon. Actually, it's a fairly common malignancy. If you are seeing 5 cases in a month, so which is a pretty high number, and so we really need to be updated on the management of extensive stage small cell lung cancer. So this is a patient who is 54-year-old male, facial swelling, erythema, dyspnea for 4 weeks, blood in the sputum, and he is a smoker. Next slide, please. And that's, you see these ecchymotic patches with the facial plethora. And I think you can guess that this is, you can see this jugular vein, which is fairly prominent on both the sides, indicating that the patient is having a superior vena cava obstruction. Next. So that is the chest X-ray. So what is the next investigation, Dr. Safalta, in this patient?
I would like to go ahead because this is almost a suspected case of malignancy. I'll like to go ahead with PET scan along with that MRI brain.
Okay. Next slide. I don't know if there's yeah. So you said it, PET CT scan, I think that will cover. And the biopsy needs to be done to establish the nature of the disease. So this was done. Next. So you can, I think the imaging is suggestive of advanced stage lung cancer. There are, lesions in the liver, and the adrenal gland is showing the left is enlarged, and the bronchoscopic guided biopsy shows small cell liver, small cell lung cancer, right?
Yes.
So, any role of NGS, Safalta? Non-small cell you're doing every day.
Yes, but no, sir. With small cell carcinoma lung, I haven't done NGS ever.
So not upfront.
Not upfront?
No, sir.
Samit?
No, sir, not upfront. Maybe as a part of later roadblock, when you hit a roadblock with these patients, maybe you can have.
So I'll kill it here by saying that a few days ago, there's a publication which has come in from US where they did the analysis of NGS in small cell lung cancer, and they identified 4 subtypes, and in which they found a particular immune signature suggesting that this is a immune inflamed kind of a subtype, and that is the type which derives the maximum benefit as compared to the other 3 types, which I think are different genes like neuro D1, AESL1, and another PALB or something type. So what I'm trying to say here is we're not doing it. It is not needed to be done, but I think keep yourself updated on the new developments on the issues of detecting who are the patients who are likely to get the maximum benefit out of the immunotherapy. And it was the latter, the immune inflamed type, which actually, they showed the benefit. So you can follow, I think that there's a lady who has published this data very, very recently in the ASCO, and it's a podcast available. So can we go to the next slide? So MRI brain, I think Safalta said, which should be done, I believe, in all the cases. And why is that, Dr. Safalta? So you are the only one, I think, who is there with us. So,
sir, we are also there. Me and Samit are there.
Yeah, sir, we'll be happy.
So we have 4 of us.
So Safalta is gonna kill us if she is the only one left.
No, she said MRI, so that's why I'm asking.
Shyam sir, we all are there. Don't you worry.
Okay, you're listening. Okay, fine. So Safalta, why MRI?
So one thing is the staging purpose, and then regarding if radiotherapy is required for like prophylactic radiation is required in the small cell carcinoma lung. That's why.
So I think the incidence of involving brain is high in small cell lung cancer. Sushant?
Yes, sir, it's quite high. So we also do routinely to stage the disease, to prognosticate the patient, and to find out in the end whether, because now the theory is that maybe prophylactic radiation may not be required, but if the patient has a brain mets at the base and in the end we get a good response, so we might be wanting to give radiotherapy to the brain.
Right. So I think go to the next slide, which I think shows you the NCCN guidelines. So where they say the brain MRI is preferred, or a CT with contrast needs to be done at the initial evaluation of patients with small cell lung cancer. So I think that will complete the staging process. And go to the next slide then. So treatment of brain metastasis in small cell lung cancer. I mean, in asymptomatic patients, chemotherapy alone was the most commonly recommended first-line treatment. But as you said, patients who get a good response from chemotherapy and, they have a PR or a CR, well, they should be given a PCI because there are ER-OTC studies which have shown the benefit there. And for symptomatic patients, I mean, of course, radiation of the brain would be recommended. And I think we'll have the next slide. Next. Yeah, so I think this is about the brain metastasis, for example, or for patients with SVC obstruction. So this is systemic therapy. We'll come to this. Next slide, please. So MRI brain was positive. Patient is asymptomatic. No history of seizures, headache, or a suggestion of brain involvement. So here you have a patient with asymptomatic brain metastasis, maybe 2 lesions there, and liver involvement, adrenal involvement. So Samit, what is your approach?
Sir, usually I would not go for radiation. I'll keep them under follow-up, repeat MRI every 2 monthly. And I think there is a Japanese style which has suggested this only, that going upfront with radiation and just following them every 2 monthly with MRI, they have equal survival. So my approach would be just to keep them under observation.
Right. So the treatment for this patient would be what? How do you proceed?
Chemotherapy only, along with probably suggest them immunotherapy.
All right. Next slide, please. So I think that's where we have the SVC syndrome, which is what will require our urgent attention because the patient is having symptoms related to the SVC obstruction. Next slide. So I think Samit already said this.
So actually, I was going through these trials, and it is like if the patient is having brain metastasis, then in that case, adding immunotherapy has not worked. It was like confidence interval was 0.7 to 2.4 like. So if the patient is not having brain metastasis, then immunotherapy is good and it has shown overall survival benefit, but not with the patient with brain metastasis. So in this patient, I would like to go ahead with cisplatin etopo.
Okay, so I think your opinion is being understood.
Atizo trial and durvalumab trial, both Caspian trial and this, it has not shown benefit with the patient in brain metastasis.
I think the next few slides will cover that particular aspect.
Okay.
And maybe we'll learn from the subsequent slides. Next, please. So I think we all understand this theory part. It's highly, very high mortality, etc. Next, please. So I think that was the question. And so anybody, Dr. Safalta doesn't want to use immunotherapy, but Sushant, what is your choice? This patient has asymptomatic brain metastasis.
Sir, I would like to use immunotherapy along with the cisplatin etoposide. If the patient is not cisplatin ineligible, I would like to use immunotherapy.
So what is against etopo and durvalumab?
There's nothing against it, sir. We can use carboplatin also. Both of the regimens can be used.
Okay.
But yeah.
Fine. So one can use durvalumab with cis or carbo with etoposide. And what about atezo?
Sir, all three indications are actually correct. Carbo can be replaced with cisplatin. The survivals are the same. Again, atezo with durva are same. But NCC and what it suggests is durva may have some edge over atezolizumab in terms of their blocks of efficacy, safety, and all these things. So all these are equally good combinations.
No, so these are very, very important points which Samit and Sushant are raising. So I think let's cover that in the next few slides because the protocol or the trials were done, with different drugs, and therefore the approvals of these drugs are not the same. And for example, the atezo trial excluded brain metastasis, whereas durva trial included brain metastasis. Can we go to the next slide? So which I'll just share with you. So now you see here, this is the Caspian study. This is asymptomatic or treated and stable brain mets permitted. So this is the durvalumab trial. And in the durvalumab trial, they had platinum and etoposide. So which I think it's mentioned bottom line here, that you can use carboplatinum, either carboplatinum AU656 or cisplatinum. So durvalumab trial included brain mets, carbo and cis. Okay. So this is the important, this is clearly mentioned here. So you could choose between the two. Next, please. Okay, so I think we already said this. Next slide. Optional PCI was offered only in the control arm in maintenance phase. So subsequently, next, please. So this is the question which we were raising or which we were discussing. So do we have the flexibility for platinum with atezolizumab? So actually, atezolizumab trial did not allow cisplatinum. So therefore, that flexibility is not there. So if you, but I think we all understand. So what is the difference between cis and carbo? Anybody can highlight that, please? Safalta?
Because cisplatin, it is like highly emetogenic, so we add dexa. So probably because of that reason, they have excluded it. With immunotherapy, they do not want to give dexamethasone. That's what I could think of.
So a lot of fluid is also required with the cisplatin,
okay.
and the ototoxicity is also a little higher with cisplatin. So that's why in clinical practice, in elderly patients, we tend to use carbo more often than cisplatin.
Right. So therefore, but carboplatinum and etoposide can be combined with either of them, atezolizumab and durvalumab, as per the trial criteria, and as per the guidelines that I'll show you. So platinum, if somebody wants to use cisplatinum in a young fit patient, well then the choice would go to durvalumab rather than to atezolizumab, because the approvals are not for cis with atezolizumab, because they did not use cisplatinum. Next, please.
Yes, sir.
Yeah. Okay, so this is again the aspects of the trial where basically they included the brain or asymptomatic or the stable brain metastasis. Next, please. So how many cycles do you give for chemo? 6 or 4?
6 cycles.
6 cycles?
6 cycles, sir.
Yes, Safalta? I think some people do practice only 4 cycles, and then one can continue the immunotherapy. Next, please. So this is 56.8% received 6 cycles in the control arm. So you can and patients receiving 5. This is So number of cycles with the EP more than 4 cycles, 81%, which is the durvalumab arm, or 86%. So you should try and go to the 6 cycles. I think this is what they're trying to say. Next, please. So this is what we were trying to differentiate between Empower 133, which was the atezo trial, and the Caspian study. And you see cisplatinum excluded in the IMpower 133. Both had carboplatinum. Brain metastasis untreated, excluded. PCI allowed in the control arm, in Caspian was included, 10% had PCI. So, you know, basically the playing on the brain here, because the IMpower 133 did not use cisplatinum number 1, and the brain metastasis, asymptomatic or controlled, were excluded from the IMpower 133. Up to 6 cycles of chemo in the control arm was allowed, whereas IMpower said we should go to at least 6 cycles. So, you know, those are the subtle differences between these two trials. So this was, I think, more liberal, having cis and carbo. Next, please. So I think we've covered this. Does brain metastasis change your treatment preference now?
Yes.
So Safalta ji, yeah. So, you know, given the guidelines or given the study entry points. Yeah, Safalta.
So here they have included those patients, but then in the when you see the forest plot, you will see that there is no difference in the patients who are having brain metastasis. That is, I will not change my practice.
So you only want
yes, they have included
alone.
it, but then
you will say chemotherapy
if
alone.
the
Right?
patient is having brain metastasis, then
so you'll have
yes.
chemotherapy alone, right? Yeah, Safalta,
Yes,
it should be
sir.
chemotherapy alone.
Yes, sir, chemotherapy alone.
Okay. Next slide, please. So this is basically the pre-IO era, dismal, you know, outcome. Overall survival, you know, 8 months or even less. Next, please. So this is the durvalumab plus EP consistently improved overall survival versus EP in patients regardless of presence of baseline brain metastasis. So this is with brain metastasis, the hazard ratio is 0.69. And here you can see 0.69, 12 months versus 8.8 months. And patients without brain metastasis, the hazard ratio is actually almost similar, 0.74, 13 months versus 10.5 months. And if you look at the forest plot here.
But sir,
yeah.
So here the confidence interval, this is crossing the midline, like 0.35 to 1.31. So along with hazard ratio, we have to see the confidence interval as well.
Yeah, if you see the patients
Am I audible?
with metastasis, the numbers are small, and that is the confidence interval, right? Here, 0.35 to 1.31. Right, I agree with you. Yeah. So, but those are the curves here. So, Sushant or Samit, you want to make any comment?
Sir, I think they had used PCI in the control arm, and what they wanted to see in the experimental or immunotherapy arm, whether they had any benefit in brain metastasis or not. So even though the confidence interval is a bit on a higher side, with hazard ratio of 0.69, I would still be adding immunotherapy with chemotherapy in such patients with asymptomatic brain metastasis.
Right. Sushant, you still want to give immunotherapy?
Yes, sir. I would like to give immunotherapy, sir.
Okay. So anybody else wants to comment from the audience or anybody else who's there? Varun, or I think you said Varun is there. Okay. So I think nobody wants to comment on this issue. Next slide, please. Okay. So this is the IMpower 133. They had, you know, very few patients with brain metastasis. And the confidence interval is, of course, you know, I mean, the hazard ratio is, I think it's a no meaning because the number of patients are so small. Next, please. So this is the overall survival at 2 years. You can see 22% versus 14.4%. So I think Samit and Sushant have already agreed on using durvalumab and Safalta. So if the patient does not have brain metastasis, then do you go for IO, or you are not happy with this,
Yeah.
this curve?
Yes.
Yeah, then you would like to use
Yes,
it.
sir. Definitely we are using it in
So in the
whosoever is
absence of brain
able to afford,
metastasis,
we are.
okay, next please.
Yes.
So I think this arrow is for the patients whom you were telling the NGS was done and they had some immunomodulatory inflammation.
Right. So of course, that is the subsequent analysis which they have done, taking patients from Empower and from Durva study. And I can tell you the name of the doctor, who has done the study. And if this thing opens up, my cell phone, yeah. So this is it is Dr. Lauren Byers. So I got to hear, and these are the 4 subsets, one is with the ASCL1, Neuro D1, PAL B2. Okay, so these are 3 subsets, and they identified a 4th subset, which is, immune inflamed, and majority of the, beneficiaries of the IO were from that particular group. The other interesting point which they said in their analysis was that these groups evolve. So if you are having one subgroup initially, for example, Neuro D1 or something, I mean, after a year or 9 months or 12 months, it can evolve into immune inflamed, and they can derive benefit from IO drugs. So this is something, as I said, for future. Of course, more than 22% patients are alive at 2 years. So this is was perhaps not there before. Virtually everybody would die at 2 years, almost 100%, but then 22% is a fairly encouraging figure. Next please. And this is the PFS. 11% patients are having no progression of cancer, and the hazard ratio is 0.8, and as opposed to 2.9% with the chemo alone. And as you can see, this curve, they tend to start separating, after 6-7 months, which is what is known to happen with the immune oncology drugs, that you start seeing the benefit, subsequently. Any comments from the panelists, please, or anybody?
No.
Agree, sir. Totally agree.
Yeah, we can go to the next slide. So this is, you see the approvals here. 4 cycles of therapy are recommended, but some patients may receive up to 6 cycles based on response and tolerability after 4 cycles. So this is the NCCN 2021 small cell lung cancer extensive stage guidelines, and durvalumab can be combined with carbo and cis, whereas atezo can be combined only with carboplatin. And it's a category 1 recommendation. Next, please. So these are the overall response rates. I think we understand. So we're running short of time. We can, skip these slides. Next, please. Of course, now the role of, PCI. So Safalta, what do you think? PCI in extensive stage small cell lung cancer.
Yes, so there is some data that if the patient has responded very well, then there is some role of giving PCI in extensive stage small cell.
And what about the local external beam radiation to the residual primary?
Yes, that also can be explored. Yes, sir.
Can be given if there is
Samit,
minimal extra thoracic disease, really minimal, can be given.
So PCI, I would really like to avoid because it really brings a cognitive dysfunction in the patient. If the patient is asymptomatic, I tend to defer PCI. Whereas local EBRT to residual primary, if the mediastinal nodes are just left or small disease left and it can be easily covered in the radiation portal, then definitely local EBRT to the residual primary.
Yeah, no, these are like controversial areas, but I think on an individual basis, there are physicians and radiation oncologists who like to do this, and I, for one, would like to do this. You can do the hippocampal sparing because the incidence of brain involvement is so high, and these patients may not survive that long. I mean, you want to delay the occurrence of brain metastasis. So maybe there is no clear-cut guideline. I think I'll just show you the guidelines. Next, please. Next slide. So this is a long this thing here. So I'll not go into the details of this. but I can read about the prophylactic radiation. In patients with extensive stage that have responded to systemic therapy, PCI decreases brain metastasis. EORTC found improved overall survival with PCI. However, a Japanese randomized trial found that in patients who had no brain mets on baseline and did not improve survival. So there is controversial data there. So one can always, select and choose depending upon your, radiation colleagues and your own thought process. But I think hippocampal sparing should be always be there. So next, please. So I think basically with the Caspian study, the durvalumab study, you can use cis or carbo, and 22% overall survival at 2 years. One can go 4 to 6 cycles. PCI is allowed in the control arm, and efficacy as per their claims is regardless of brain metastasis, although Safalta has strong views on reserving durvalumab in patients with brain metastasis. So I think with this, we come to the end of this panel discussion. Thank you very much, Dr. H.P. Singh. I think we have covered all these points here. So over to the chairperson, and thank you very much.
Thank you, Dr. Sham. As usual, I think you always bring up a lot of interesting points. You educate us so well and bring us to the subtle points. I'm still, panel discussion is open for any questions, answer to the panelists and to Dr. Sham, please.
Sham sir, I have a question. If patient is not willing for immunotherapy, are you tempted to give more than 4 cycles, like 6 or 8 cycles? Because these patients would actually respond upfront, then once they relapse, it's very difficult to control the disease.
Right. I mean, extensive stage patients have a dismal outcome because the relapse rates are more than 80–90%. If somebody is tolerating responding 4 cycles, I normally would like to go up to 6 cycles. And I, for one, if somebody has residual disease in the mediastinum, will consolidate and give PCI. I'll go all out because, once they relapse, you have drugs like irinotecan, which are available, but, or even taxanes are available. This is what we normally use. But, the outcome is so dismal in relapsing patient. So whatever you want to do that in the first go so as to, delay the relapse. Well, that will be my take. So, Dr. Safalta, your thoughts on 4 versus 6 and the, as Samit asked?
So, we generally go ahead with 6 cycles of chemotherapy if we are giving chemotherapy to these patients. So, no other thoughts.
Right.
Sir, I'm having COVID after 2 doses of vaccination after 6 weeks.
Oh God. so, it must be mild one, right?
Yes, mild one. And my husband is hospitalized. उन्होंने एक ही dose लगवाया था.
Okay. So 4 people in Gangaram have COVID after taking 2 doses of the vaccine. So you're not the only one. All of them are at home. And I think 2 of them have already recovered. 2 of them, I believe, got that in the last 2-3 days. But they're all at home. Nobody requires hospitalization. So I think you are fit for the panel discussion. Yes, and in the next 5 days, you want to be fit for BL Kapoor.
You can see my face.
Thank you, Safalta.
Yeah, I just wanted to comment that you're looking a little unwell, but then, at home, you just never know. So get well soon, Safalta, and best wishes for your husband as well.
Dr. Sham, before we conclude,
Thank you, sir. Thank you, sir.
Speedy recovery, Dr. Safalta, to you. Dr. Sham, still I'm not very clear by your discussions you all had quite extensive.
Yes, sir. Yes,
sir. Should we, sir, use immune checkpoint inhibitors with CNS mets or not? What is the final consensus statement from your panel, sir?
So the consensus statement is that in the Caspian, so one thing is not to use atezolizumab at all because they excluded patients with brain metastasis. So the Caspian study included stable, brain metastasis or asymptomatic brain metastasis. And as Safalta is saying, she doesn't want to use, that is basically a subset analysis. If you look at the full curve, of all the patients, There the hazard ratio is to the tune of 0.7. So, I would, like
but
to...
that was predefined subset analysis. It was pre-specified that they will be doing this subset analysis of brain metastasis versus no. So it was powered actually.
I'm not sure whether it
Sorry
was
to
powered,
interrupt you, sir.
because the numbers were I believe 55 or so. But then, whether you have the power to delete those patients in this, but the label doesn't say that. You can include patients as per the Caspian study. That is my take on this. So if you are giving the patient durvalumab in a patient with controlled or asymptomatic brain mets, I do not think that you are doing wrong. Sushant?
You're not doing wrong. Yes.
I agree, sir. I agree.
Right. So it is your conviction, Dr. Singh. The label does not exclude brain metastasis.
Okay, Dr. Sham, I think we have reached to some consensus, and maybe next meeting when we have a small cell cancer, we come with a very absolute yes or no. Right. And so you leave it at us. Thank you very much, Dr. Sham. As usual, it is a pleasure listening to you and your team. I think you brought in very interesting points, and we look forward to having more discussion with you, sir. And with this, today's conference comes to an end. I hand over the conference back to the organizers, Dr. Mittal and Dr. Purohit, to kindly take over. Thank you.
Thank you, Sham sir, for such a thorough discussion on a very left out topic, small cell lung cancer. And with this, we come to the end of today's session. I would like to thank all my chairpersons, Dr. H.P. Singh and Dr. Doval, all my speakers, both national and international, and all my panelists for such a illustrious discussion. And I would like to thank my sponsor, AstraZeneca, again, for sponsoring today's session. And with this, I bid you goodbye. Keep safe and get well soon, Safalta. Take care.
Good night. Good night. Thank you.